First hearing of the committee's inquiry into the prevalence, causes and impacts of loneliness in New South Wales. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians on the lands on which we meet today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name is Dr. Sarah Kane and I'm the chair of the committee, and I ask everyone in the room to please turn off their mobile phones, turn them to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome, Professor Lim, and thank you for making the time to give evidence. Just before I get you to state your name and swear an oath or affirmation, I'll just note for you that we do have two inquiry members online with us at the moment, Mr. Scott Barrett and Mr. Bob Nanva.
Thank you.
Would you please state your name, position, title, and swear either an oath or affirmation?
Associate Professor Michelle Lim, CEO of Ending Loneliness Together, Associate Professor of the Prevention Research Collaboration at the University of Sydney.
Thank you. And would you like to start by making a short statement?
Yes. So my name is Michelle Lim. I am, as I mentioned, an Associate Professor at the Prevention Research Collaboration in Sydney, and also CEO and Scientific Chair of Ending Loneliness Together. Ending Loneliness Together is seen as the national authority in the area of loneliness and connections. We have about 65 organizations that do channel into our network. So we are currently involved in assisting the Victoria, Queensland, South Australia governments in various activities aimed at targeting loneliness. I'm also the founder and vice chair of the International Scientific Board of the Global Initiative on Loneliness and Connection, which supports about 28 countries around the world on their agenda with loneliness and social connection. So in the late 2023, I was appointed by the World Health Organization to serve as one of 20 experts around the world. This role is to assist the Secretariat on their activities in their commission to social connection. For example, we are assisting the development and launch of the Commissioner's Report at the WHO, which will be released early next year. So the evidence that I bring today will be aligned with the World Health Organization's approach to this issue. And I really urge the committee to over the next couple of weeks to think really deeply about the solutions and strategies targeting at-risk communities. It takes an average of 17 years of evidence to change practice on the ground. And the kind of questions I really hope that you do keep in mind are really things about how strong are the evidence on particular interventions? Have they been evaluated, or do they simply show associations? Are these interventions actually measuring loneliness, or do they simply address social isolation? Because we do know that those issues are different. Just because you are connected to people does not mean you are less lonely. In fact, having particular social connections and social relationships can also be unhealthy. So they're not necessarily always healthy for us. Those are some of the things that I hope that the committee will kind of take in mind.
Excellent. Thank you very much. Sorry, can I just check? She's got them in front of her. Professor Lim, I think you might have perhaps skipped the oath part.
Oh, yes, I did.
think you told us
Yes,
who you
yeah.
were. Would you
I was
mind
wondering
Yes.
why that, yeah.
Yes.
So I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you so much. Appreciate that. And thank you again for being here and for Ending Loneliness Together's submission. And from reading a number of the submissions, it does appear that the work that you've been doing in Ending Loneliness Together really has kind of been the basis for a lot of consideration of these issues. So we appreciate you being here and kicking us off today. And I just wanted to pick up a bit more on what you've just mentioned in your introduction about, because we tend to talk about, and in our terms of reference, we do talk about loneliness and social isolation. Could you explain a bit more the difference, but also why it matters that we think about them differently?
Yes, I will, and I will align with the World Health Organization's definitions. So loneliness is very much a subjective experience where you feel like you do not have those meaningful relationships that you desire. So there's a difference between what you have versus what you hope to have. Now, loneliness can only be assessed if you ask someone specifically. It has to be measured. You can't actually observe that as a third person. Social isolation is very much more of an objective state. I can see as a third person whether you may be more vulnerable to social isolation if you do not have people around you, you have fewer social contacts, fewer group memberships, less social interactions around you. Now, how we would tackle that issue is very different. One is very much based on quality and improving the quality of those interactions, and the others around just simply providing social opportunities. And a lot of the interventions that you might hear over time is that they do bring people together. My question back is whether do they make a meaningful difference to loneliness, and do they measure loneliness as a primary outcome? And those are the kind of questions I tend to ask myself.
Could I ask you a bit about that? Because as I said, we've been sort of reviewing other submissions, and I am a bit interested in the research side of things. You're clearly across it. Is there any other data or research that you would point to for us to consider? Because as I said, a lot tend to refer to your work. Is there anything else that you could point us to that's useful?
Yeah, look, we do also use the Hilda survey, for example. And as you know, the Hilda survey has some loneliness questions, but we have recently also validated some items there and actually distinguish what loneliness is versus social isolation. Okay. We do know, for example, the prevalence of what we call episodic or transient loneliness versus persistent loneliness. They're quite different.
Yeah, thank you. In your report, you cite that New South Wales residents reported the highest prevalence in the country, with 29% meeting the criteria for loneliness. Can you explain this a little bit? Is that 29% extrapolated across the population? Was it 29% of respondents?
29% of respondents, but those surveys are actually benchmarked and weighted according to ABS profile.
Right, okay.
But I would like to state very clearly that when we look at cross differences across states, there's no significant difference. Right. It's just that New South Wales is reporting the highest. So just be very, very clear about that. Right,
okay. And when you talk about meeting the criteria for loneliness, can you talk us through what the criteria are?
There's a bit of a cutoff score that we use with a psychometrically validated scale, which is the UCLA loneliness scale. And so we actually have a criteria for loneliness at any given time, and then kind of more severe end, so kind of more of the top end, where we found that 1 in 6 Australians report severe levels of loneliness, but only 1 in 3 would report loneliness at any given time. So you can hear that the prevalence is really high. I'm not really concerned very much about the high prevalence, because loneliness itself, from an evolutionary point of view, you are meant to feel lonely. It's like you are meant to feel hungry, you're meant to feel thirsty. What I'm concerned about is persistent loneliness, right? So we are living in an environment that do not facilitate us initiating, developing and maintaining social connection that's meaningful and healthy to us. So in this year, we actually look at longitudinal data, and I'm more concerned that 1 in 4 Australians report what we call persistent levels of loneliness. So this is actually meeting a minimum criteria of at least 8 weeks, up to 16 weeks. And depending on where you look, including the Hilda survey, we also looked at people who meet criteria for 1 year and people who meet criteria for 2 years. I'm more concerned about persistent loneliness, because we know now with emerging data that loneliness, yes, it's bad for our health and well-being, but when we actually have those persistent states or more chronic states, that's where we actually exacerbate our incidence of higher mortality, and as well increase our risk to developing future health problems.
Okay, thank you. again, throughout the various submissions, there's discussion about which sort of age cohort or which demographic group experience higher levels of loneliness. And I think in your research was interesting in that it was younger people, 18 to 24. Can you talk us through that a bit? And has there been an attempt to sort of figure out what's going on with that group?
Yeah. So I would like to state as well that, depending on the survey that you look at, there will be different age groups. It really depends on the sample.
Yep.
So in kind of international data, we have younger people, and then sometimes middle-aged and older adults might report loneliness. It really depends on how you measure it. I wonder sometimes when I do look at these data whether it is that young people are just more comfortable in reporting their loneliness. Perhaps there is an intergenerational bias where older people do not allow themselves to use the term lonely or have this perception that they shouldn't be feeling this way. So I would not discount the fact that older people experience loneliness. They certainly experience social isolation, which is a pathway to loneliness. So we can't neglect other age groups as well. And of course, the middle age group as well does come up quite a bit. And not much research has been looking at the causes of that middle ages. But some of the hypotheses around that might be that they might be in a parenting role, a caring role. They do not have time to really develop and maintain meaningful social connections for themselves because they're really overburdened by those responsibilities.
Mm-hmm. Thank you. I've got plenty of more questions, but I might check in. Yep.
Thank you so much for coming to share your expertise today. I'm interested that you're representing a national organisation. You're obviously doing some very impressive work internationally as well. What are the lessons from overseas or other jurisdictions that we should be looking to?
Yeah. So what we have looked at is different kinds of interventions. We have a lot of investments in interventions focused on the individual level and some on the community level. I would, of course, advocate that we do need to look at these at-risk communities. However, government has the opportunity to look at population-wide strategies as well. So given that there's a high prevalence of loneliness at any given time, 1 in 3 of us will experience it, what we're really trying to do is to prevent that 1 in 3 to go on to develop more persistent loneliness. Only government would be able to kind of have a strategy where we have this population-wide initiative, and it could look like different ways. So it could look like improving community awareness on the national level. We have Loneliness Awareness Week, but that's very much limited in terms of its funding. We can only do so much with very limited funding. We had in this year, just in 3 weeks, Loneliness Awareness Week yielded around, I think it was around, I would say 286 million media impressions just in 3 weeks. 2,000 people saw connection. People went to the website to look at how they can actually help others or help themselves. This campaign is really limited and it needs to be scaled up, but that would be an example of a population-wide strategy. Other population-wide strategies could be things like building the capacity of health and community services to understand, assess, or appropriately respond to people at risk of loneliness. Implementing workplace policies that provide opportunities for employees to feel included and supported at the workplace. Implementing policies to ensure that employees are not overly burdened at work and there actually is sufficient time to focus on their personal lives and building quality interactions. Implementing educational policies to children, adolescents, and young people where they can learn to navigate social relationships. And incentivizing the community to engage in shared activities in their neighborhoods. So we can do more. Basically, what we have found is a lot of evidence in the individual and community level, nothing in the population-wide strategy, which actually has been advocated for in the public health sector, that we don't spend enough time on prevention. And they don't cost much more, and they have value for money, but we need to actually do those ones.
Nice one.
Yeah.
Thank you. the top recommendation that you've made in your written submission was commissioning an evidence-based statewide strategy to promote social connection and address loneliness.
Yeah.
And you mentioned a couple of examples from elsewhere. Which one of those would you see as best practice in terms of other states or overseas?
Yeah. So we've just recently looked at this kind of on a global level. Around 9 countries around the world have a strategy already to address loneliness. Another 7 have loneliness included in their related policies, so social, community, and mental health. We are probably 1 in 4 countries around the world that have done economic costings of loneliness, but we do not have a strategy. So I think we are a little bit behind in that we need to coordinate efforts. Loneliness is a highly prevalent issue, but not easily resolved because it's an intersectorial issue. Without that coordination, bringing in multiple stakeholders from across different portfolios, working with government stakeholders, people with living experience, scientific experts, we need to have a strong foundation to actually base our actions from. Every country is different. I know, for example, Denmark's strategy, for example, they commission their strategy to experts on the ground. That's an example. Or other governments might do within government strategy and coordinate their efforts by themselves. What I really hope to see much more, and which I notice, is that these strategies are not evaluated, and some of them are not implemented, which is a worry because then you have a strategy that just sits around and does nothing. So if we were to go down that line, I think making sure that it's implemented well and evaluated would be a very sound approach and a great opportunity for New South Wales to start.
Thank you.
Thank you. Thank you.
Thank you very much for coming today. I just have a couple of questions. First one's around, I suppose, the definition and if there is a universally accepted definition of loneliness and social isolation. If you could outline the difference between those.
There is, and you will see those definitions when the World Health Organization does release their report early next year. But in brief, loneliness is subjective. It's a distressing or aversive feeling that comes up when you feel your relationships do not meet your current social needs. And social isolation is objective, so you have fewer social relationships, contact, interactions with people. Now, again, one is observable and the other is not. So when we think about intervention solutions, we don't really know the impact unless we ask people about, do you feel less lonely because of the intervention, or do you feel meaningfully connected because of this intervention? And I think we can do a much better job evaluating loneliness.
And I suppose you mentioned has been some economic costing around loneliness. So how can you measure loneliness and social isolation?
Yeah, I think that we can have a strategy in New South Wales, for example, population health surveys, where we can actually implement validated loneliness measures or short, brief measures that have been used by, say, the UK, for example. The Office of National Statistics do have a 1-item loneliness scale that looks at frequency and also measure well-known indicators of social isolation as well. So some people do take crude indicators around amount of social contact that someone has. Other surveys also have related constructs like living alone status, for example. I would recommend a combination of those, but those can be really easily implemented in New South Wales population health surveys.
And I know that I think Queensland did the loneliness inquiry a few years ago. ACT's only a few months ago released their report, and I'm not sure if Victoria, I think, might be still going through theirs. I suppose and you referred to a state, New South Wales strategy. How important is it to look at it from a national perspective, particularly around a universally accepted definition and how things are measured?
Yeah, look, I think what we don't have, and this is something that we've been trying to do as a national organisation, is to set the consensus definition and to ensure that everyone's thinking about the issue the same way.
Yeah.
And so we talk about specific measurement using a loneliness outcomes framework. We talk about measuring programs, asking people questions the same way so that we can have a benchmark to compare interventions with other interventions. Because we're not using them or using the same kind of scales, it's very hard to determine the effectiveness of those interventions.
And this is more of I suppose, a health question. We know that there is a link between loneliness and social isolation and poor health outcomes. Has there been more work done to sort of break it down to the psychological and the physical impacts on a person's health?
Yes, we are at the moment doing some research with the Lancet. For example, it will not be launched till next year, but we look at the mechanisms of the pathways from loneliness and social isolation to mortality or poor health. And there are pathways, so psychological mechanisms are one, restorative pathways like sleep quality, health regulation behaviors are another, and physiological pathways as well, so brain biology and genetics. One thing that I want to really stress is that loneliness is really experienced in the brain as a biopsychosocial stressor. So when we are physiologically stressed out, we would also then have that impact on our psychological health, and we are less incentivized to keep healthy. We are less incentivized to exercise. There's also no one nagging you to do those things. We're less incentivized to eat well, live well. And therefore, if we are lonely and we do not address those things promptly, or we do not have the resources around us to help us, that is when it leads to higher mortality and higher morbidity of health disorders.
Thank you. And my final question is in relation to your, I think it's number 3 recommendation about evidence-based training programs for frontline practitioners in New South Wales. I just wanted to ask if you're aware of, because this was a similar recommendation that came out of the Queensland inquiry. So I'm just interested to know if you're aware if Queensland has advanced any work in that space and any examples of some practical programs that are actually being rolled out, whether it's here in Australia or overseas.
I'm not. I do know. I'm not sure if I'm allowed to speak about them. But what, and that's one of my recommendations for the Queensland government as well. What we don't have, and I would just even kind of relate this to psychology practice, which I'm a registered clinical psychologist, is we do not have specific training even within our mental health sector about what loneliness is and what it's not. So Ending Loneliness Together was commissioned to do a series of training in Victoria, for example, and we went out to mental health practitioners on the ground. And what we found was that the things that we were teaching around social connection, loneliness, and social isolation was it was new to practitioners. The way I was trained was that we were very much focused on mental health, suicidal risk, maybe physical health to ensure that, but we don't think about social health until we try to discharge someone off the books, right? So we need to have a system change in the way we train mental health clinicians. And we're doing some work on the ground already on ensuring that people understand the 101 of how we improve social connection. Again, remember, it's not simply connecting people. I think when we connect people, if you feel ambivalent, and I say ambivalent, so you're not sure about the relationship, or if you feel negative about the relationship in which you just gain, you will still feel lonely. So really getting practitioners to understand, sure, you connect someone, but what is the next step? And how do you know they're less lonely? Because you could connect someone and they actually feel more lonely. And being lonely in a group, for example, lonely in a marriage, lonely within your neighborhood, is something that people talk about all the time.
Yeah. Thank you very much.
Thank you.
Nice.
Yes,
Sorry.
Mrs. Yadam.
So you've talked about loneliness and social isolation being two different things, one subjective, one objective. So I wanted to kind of, perhaps delve into the question around which has the more adverse health impacts?
They're equivalent, so there's no significant difference between the two. In traditional research and medical research, the impact of social isolation on poor health has been researched very well. And in fact, starting from things like animal models, where they actually isolate mammals, for example, and see how their health is and how they actually interact. But in more recent years, it's not about being alone that hurts our health, it's feeling alone that hurts our health. And we see emerging data even in young people, where in a recent study that we did, we could see signs of vascular aging in young people as young as 22. If they feel lonely, we're seeing signs of vascular aging early on. So they don't have chronic disease just yet, but loneliness has a profound impact on deterioration in an early stage. So this is why I talk about prevention quite a bit, because...
So is it possible then to be socially isolated without health impacts?
My colleagues in the social isolation research would say it's equally bad for you. And the data is saying that equivalently, we know that if you're socially isolated, you're going to have a higher chance of cardiovascular disease as well. So they both are bad for health. If you have one and not the other, that's bad. If you have both, that exacerbates it. They're synergistic, if you might kind of put it that way.
Okay, thank you.
Thank you. I'm just checking with that online. Mr. Barrett or... yes, Mr. Barrett.
Yeah, if I may, thank you. Thank you, Professor Lim, for jumping on. Sorry, my questions are going to be a bit scattered and not linear. They might also seem a bit obvious, but it's important we get some of this stuff on the record. So my understanding then, there's a bit of a progression from there's a chance of a progression from social isolation, then to experience loneliness, then to feel lonely through to severe loneliness.
Yes. So what we're saying is, again, I guess keeping in line with the current perspectives that we have out here, is that feeling lonely, again, is an innate signal for us to do something different about our social relationships. And if we ignore it, or if we do not have the resources to manage our loneliness in an effective way, that's when it will lead to poor health. Now, when that's the case, is something that researchers have not figured out. And it could be a subjective threshold, because as I mentioned, loneliness is subjective. So we do not know when someone is lonely and how long they need to be lonely for before it leads to poor health and mortality.
So maybe following on from that, one of your, who is affected by loneliness, can you just tell us a little bit more on why those reporting financial hardship would be 7 times more likely to experience to have persistent loneliness?
That's a fantastic question, Scott, because that's something that came up for us unexpectedly. And with this climate of everyone kind of being in a financial strain, we're concerned about that. And when I look at the international data on that, we also see that people from lower socioeconomic backgrounds who are more disadvantaged in terms of income are particularly affected, disproportionately affected. And the result that you see there is, even after we account for age, gender, health problems, the impact, so we account for all these variables, and we still find that people who perceive themselves to be financially unstable or do not have their financial needs met are almost 7 times more likely to experience persistent loneliness. We do not have the detail of why that's the case, but one can hypothesize that being financially strained changes the way, first of all, we see relationships, changes our capacity to maintain social relationships, things like time, things like activities. So a population-wide strategy, for example, could be to ensure that there are low-cost, no-cost type of activities for people to engage in. People who, they need accessibility and they need safe spaces in the community to have these social interactions that are meaningful and healthy for them.
come back to the other ones because this sort of flows on to your recommendations. Your second recommendation, among other things, talks about developing a framework to guide and promote social connection. So what are some of the things that could help that social connection?
So, so when I say social connection, just for everyone's sake, loneliness and social isolation are, according to what we agreed with the World Health Organization, are two forms of social disconnection. There are other forms of social disconnection, such as lack of social support. And social connection would mean having less loneliness and social isolation in this space. So with the competency framework, really is really focused on training people on the ground across sectors to know how to respond accordingly, what to say, what not to say. And we need people who feel lonely to feel safe to actually get the help they need. Because what we do know is that there's a huge amount of stigma around loneliness. About 1 in 2 Australians who do feel lonely actively conceal their loneliness and do not want people to know that they feel lonely. And because they're actively concealing and not getting the help they need, that is when we actually get into, I guess, the risk of developing persistent loneliness.
Thank you. You've also put a dollar figure on what loneliness is costing per year. You're at about $1,500 per person. Who is wearing that cost?
I would say the government, but I believe Professor Alan Duncan would also be giving evidence, and he is the lead author on that paper, and I think he can kind of really give you a very specific breakdown on where those costs lie. I believe that some of those are hospitalization costs. Just to note that I don't believe that the social and educational outcomes have been costed. So if there's only a health focus, loneliness also has a burden on other kinds of poor outcomes, such as education and social outcomes.
Thank you. Thank you. Mr. Barrett, do you have any further questions for now?
I do, but I'm conscious that there's others that haven't asked questions yet.
Okay, we'll come back to you potentially shortly. Taylor, you're good?
Thanks.
You're good?
I had another question, which was just about periodisation. So, like, what's the evidence in terms of, I suppose, experience of loneliness in early life versus later in life? So, is it the case that there's evidence of, persistent loneliness that goes for the whole course of someone's life, or is it something that might be experienced in different stages, in different to different extents?
That's a great question. I'm not entirely across the research in that, but I do know that there's a lot of studies in children and adolescents and looking at early experiences of loneliness and how that trajectory means that they actually report poorer educational outcomes. But I don't believe those surveys actually track those children long enough for us to know how far those detrimental effects are. So usually they track them within 4 to 5 years, and they can see earlier loneliness predicts poor educational and social outcomes down the line.
And my other question was really about the, obviously in terms of government, it's a prioritisation question, and the relative risk, I suppose, of loneliness in terms of adverse social impacts versus the sort of other risks and other types of interventions that can be made, if you're taking a public health approach. Why is loneliness more of a pressing issue than, say, diabetes or, other forms of...
In the last 20 years, we've had an acceleration of robust scientific evidence that have found negative impacts of loneliness on health. Prior to that, we haven't. If I kind of think about what we have done for things like obesity, we have guidelines to talk about how we can prevent obesity. And the detrimental impact of loneliness on obesity is fairly equivalent, but yet we don't actually have any guidelines on having meaningful social connection. So I think it's kind of overdue. And it's an issue that the World Health Organization is trying to reposition. This is not a soft issue. There is enough evidence for them to invest millions of dollars to have a high-level commission around the world. This is also not an issue that's just a high-income country issue. This is also an issue for low-middle-income countries. So it's enough evidence for us to do something about it. What is difficult is about how we do it, where do we start, because there'll be a lot of people who want investments in particular types of interventions. But I really think about the value of government being able to widely implement and make a difference across the population. And that's where the power of government is. And what I do see is there's a lot of interventions out there that are evaluated or maybe not evaluated at all, and they can't be scaled even if they're effective. That's the issue we have. They're all working in silos. A lot of interventions are really also led by very poorly resourced community organizations. They don't have any support to scale up. They don't have any support to do more. So our efforts are really very limited and very siloed, and this is where government can really do a robust, sound strategy and implementing and evaluating that strategy and thinking about widely, not just the what we call high-risk populations, but also population-wide kind of strategies.
Thank you. I've just got a couple. One might be quite quick. In your recommendations, you note that your research could be further broken down by jurisdiction. Is that something you already have, or it's something you could do? I'm thinking more about New South Wales, obviously.
Yeah, we could do that.
Right, okay.
And we could. I think it's very easy for us to scale up, but there are. It depends on whether you want to use existing data sets, which may not fit for purpose for the New South Wales government.
Right.
But we can easily run statewide populations and longitudinal populations. I just kind of flag that because we know very much a lot about what's happening at a cross-sectional level. So we know the associations across that. What we don't know is how those things fluctuate over time.
Yep.
And this informs interventions. This informs solutions and strategies. And I would really highly recommend a much more longitudinal approach so that we can make a big difference.
And a related one that I know Mr. Barrett wants to ask, but for the purposes of keeping it quick, regional versus metropolitan, have we got, is there anything that can be broken down there?
Yes, from our State of the Nation survey, we do see higher levels of loneliness in remote, rural areas of Australia. What we don't have is the reasons why that might be the case. And what we can do to help our rural communities. I think that we need to really dive into different kinds of methodologies that can actually answer those questions.
Yep, thank you for that. And I have one last one. I know we're running out of time, and it's not quite on that point, but I was a bit intrigued, and it goes a bit to what the questions you were asked by Ms. McLaren-Jones, is that you make the point that lonely people are less engaged in physical activity and more likely not just to be on social media, but to have social media addiction, I think is the framing.
Yeah.
And I wanted to ask, have you measured this? And could you just explain that a bit more? Because, you read there are some good things about there, but this sounds to be at an extreme end. So if you could just explain a bit more.
I will just speak to the cross-sectional data that we have at the moment from the State of the Nation report. And just for the purposes of the other members of the committee here, what we do see is that there's an association of loneliness and problematic social media use. And that means one needs to check their social media accounts all the time. If they are not on them, they feel adverse effects from them. So this is problematic addiction. What we found was the frequency of use wasn't associated with loneliness, but it was really if you had the problematic use. That's the difference. And what we do also see is that's an age effect. So we don't see that effect in older people. We only see that effect in younger people. So it's basically indicating that we may need to think about guidelines for younger people in terms of how they navigate social media use, and also not compromising face-to-face interactions. So being still skilled and confident to manage their social interactions that's happening face-to-face.
Thank you. I suspect there might be some more questions, but but we're almost out of time. So thank you again for joining us here today and for the submission. I don't think you took any questions on notice, but there's a few questions we might not have got to just in terms of timing, so we might send those to you as supplementary questions. The Secretariat will be in touch about that.
Thank you.
And again, thank you so much for being with us today.
Thank you very much to everyone.
Thank you. Thank you very much. We'll begin our next session. And I do note that as well as having quite a few witnesses online, we also, for the witnesses' benefit, we also do have inquiry participants, committee members online as well. So you may get questions from there as well. Thank you very much, and we will start and making the time to not only be here today, but for your submissions as well. We are going to get you, before we start, to state your name, position, title, and swear either an oath or an affirmation. And we're going to start in the room with Mr. Gambian.
Thanks, Chair. I'm Chris Gambian, Executive Director of Australians for Mental Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. And now we might go to Ms. Traynor.
Good morning, Stephanie Traynor, Policy Advisor at Suicide Prevention Australia. I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Ms. Henriksen.
Hello, Rebecca Henriksen, Director of Government Relations with Suicide Prevention Australia, and I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. Ms. Dober.
Hi everyone, my name is Carly Dober. I'm a psychologist and director at the Australian Association of Psychologists Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. And finally, Mrs. Curran.
Hi, I'm Amanda Curran. I'm the Chief Services Officer for the Australian Association of Psychologists. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you all. And we're going to ask if each organisation wants to make a short statement. And again, we're going to start with Mr. Gambian.
Thanks, Chair, and thank you for the opportunity to say a few words today. Australians for Mental Health is a citizen-led social change group dedicated to fighting the root causes of mental ill health and determined to create an Australia where everyone's mental health can thrive. Loneliness is not, of course, a mental health condition, but the two could not be more closely linked. We know that people experiencing mental health conditions can be at extreme risk for experiencing disconnection and isolation. Likewise, we know that people who lack strong relationships and connection are at a much higher risk of experiencing a mental health condition or exacerbating the symptoms they are already experiencing. The polling we've conducted confirms what others have said. At any given moment, a third of us feel lonely, and the experience of loneliness doesn't discriminate by age, gender, class, or geography. This is the pandemic that not enough people are talking about, and I congratulate the committee and Minister Jackson for taking on this important work. But there is a risk that we think about our opportunity to make change in the wrong way. There will be many worthy programmatic interventions suggested, and we support those. There will be more abstract observations about loneliness, and that is understandable. Coming up with a concerted policy response to something as big and indistinct as loneliness is a bit like coming up with a concerted public policy response to the weather or poor dress sense. Some of us will roll their eyes at what they might think is the ultimate expression of the nanny state. I urge you not to fall into either of those traps in this inquiry. And I urge you to consider the modest structural responses that can be the catalyst for meaningful change. By asking local government to consider the opportunity to drive social inclusion and connection, funding it to deliver, and holding it accountable for that delivery, we believe that the lives of literally millions of Australians can be improved. No side of politics owns this issue. It's not ideological, and it should not be partisan. Tackling loneliness should be a priority for everyone in this parliament, and I thank you for taking these first steps towards that goal.
Thank you, Mr. Gambian. And Suicide Prevention Australia, do you have a statement?
Thank you. Thank you for the opportunity to present to the committee today. I'm Rebecca Henriksen, Director of Government Relations, and I'm joined by Stephanie Traynor, our Policy Advisor, who brings with her lived experience of suicide. Suicide Prevention Australia is the national peak body to provide a collective voice for over 350 members, representing more than 140,000 workers, staff and volunteers across Australia. More than 3,000 people die each year by suicide, and each suicide has a ripple effect through families, friends and communities, emphasising the importance of considering suicide in a whole-of-government, whole-of-community approach. Clear linkages exist between the feeling of withdrawal from social connections and the risk of suicide. This is true across all age ranges, and a lack of connections influences the risk in adolescence. Marital status is a strong association, and levels of social integration across men and women have a direct impact. Loneliness can have a lasting impact. Children experiencing loneliness in middle childhood, for example, are more likely to demonstrate suicidal behaviours in their teen years. Loneliness is a significant issue in New South Wales, with nearly 1/2 of residents reporting experiencing loneliness. In the context of this inquiry, Suicide Prevention Australia is calling for community-based interventions, enhancing research into linkages between suicide and loneliness, and suicide prevention training for key contacts within the community. There is scope to co-design programs and interventions with priority populations to provide the most effective responses, especially when incorporating lived experience, to resonate in a way that generalist interventions won't do as effectively. For people with lived experience of suicide, there are many factors that can lead to or exacerbate isolation. Reconnection with life and the community is a difficult journey. In terms of enhancing research, we know the impacts, but research is needed to better identify effective strategies and services to address loneliness and prevent suicide. The Commonwealth Government funds suicide prevention research at a national level through the National Suicide Prevention Research Fund, managed by Suicide Prevention Australia, which provides a valuable source of world-leading but localised research. Finally, it's a critical moment when a person discloses their distress or suicidal thoughts for the first time, and it will often be to a community member, such as a pharmacist or a barber. Equipping these people with suicide prevention first aid training gives them the ability to provide vital assistance and sensitivity to help reduce that person's risk of suicide. This passing connection allows for life-changing intervention. The opportunities provided by this inquiry to equip New South Wales with measures to reduce loneliness and suicide risk are valuable, and Suicide Prevention Australia thanks the committee for their consideration of these important issues. Thank you.
Thank you very much, Ms Hendrickson. Australian Association of Psychologists.
We thank the Chair for allowing us to share our thoughts on the issue. The AAPI is a leading not-for-profit peak body representing psychologists Australia-wide. We advocate for ease of access and affordability so all Australians can get the psychological help they need when they need it. The AAPI is committed to advocating for the mental health and wellbeing of all Australians and recognises the profound impact that loneliness has on people living in New South Wales. We are seeing a significant rise in the challenges associated with loneliness and social isolation, which have become pressing public health issues across New South Wales. Various stresses, including the impacts of urban sprawl, lack of access to social infrastructure, the COVID-19 pandemic, and now the cost of living crisis have exacerbated these challenges. While loneliness affects people across all demographics, certain groups in New South Wales are disproportionately impacted. Elderly individuals, young people, people living with a disability, and those in rural and regional areas with limited access due to transportation and social infrastructure are particularly vulnerable. Loneliness in rural and regional areas often goes underreported, while urban sprawl and the privatisation of public spaces further diminish opportunities for spontaneous social interactions. This intensifies isolation, particularly for those who face already significant barriers to connection. Furthermore, the urban poor face risks with limited access to recreational spaces and social activities that often require financial resources. Loneliness is not only a cause but a consequence of mental health issues, particularly anxiety, depression, and stress-related disorders. For vulnerable populations such as young people, the elderly, and people who have experienced bereavement or family disconnection, loneliness can lead to more severe psychological and physiological decline. In young people, this can manifest as low self-esteem, increased suicidal ideation, and poor academic performance, while for the elderly, it can contribute to cognitive decline and a higher risk of dementia. Specific groups within New South Wales, including men of all ages and single parents living with children, face particular risks of chronic loneliness. The lack of adequate social support networks for these individuals can lead to vicious cycles of withdrawal and increased isolation. Access to mental health services remains a significant barrier for those grappling with loneliness. The current Medicare rebate system for psychology services did not adequately cover the costs of quality care, leaving clients with substantial out-of-pocket expenses. This financial burden discourages many individuals from seeking the support they need, exacerbating their isolation and mental health struggles. Increasing the Medicare rebate to $150 per session for all psychologists would greatly improve access to essential psychological care, making it more affordable for individuals dealing with loneliness and related mental health challenges. We recommend a comprehensive investment in initiatives that will improve mental health outcomes for all Australians, including the introduction of more accessible Medicare rebates for psychological services, targeted funding for services in rural and regional areas, and greater support for communities experiencing heightened social isolation. By prioritising accessibility and affordability, we can ensure that no Australian is left without the care they need to overcome loneliness and build healthier, more connected lives.
Thank you. Thank you all very much for that. And now we'll be going to questions. Mr. Gambian, I might ask, before I ask you about one of your recommendations, could you just tell me a little bit more about the poll that you mentioned and is in your submission, just so we get a sense of what that was about?
Yeah, so a couple of times we've been running what we call the Australian Mental Health Monitor, which is a poll ostensibly about mental health and asks a series of questions related to mental health. One of those questions is just a sort of people are given a series of propositions, statement-based sort of propositions, and they're asked to answer yes or no. And one of those is, I have enough connection in my life and I do not feel lonely. And roughly a third of people are saying to us that it's not in fact true for them. It's a higher number in regional areas, and if I was more organised I would have actually brought the specific figures. It might be in my submission. But it's higher in regional areas. Young people are a surprising cohort of people who are saying that they don't have enough connection, which I guess is ironic given that stage of life, but pretty consistent with, I think, what you heard in the evidence of the previous witness and what is in the sort of common discussion about loneliness.
And can I ask, just because we are comparing a lot of research today, just your sample, who is it that you asked?
Yeah, it's a random sample of Australians, so it's a poll conducted by UCOM. Okay. There's about 1,500 responses across Australia.
Thank you. Sorry, we're just dealing with a lot of different research. And so I want to ask you about your recommendation. One of your key recommendations is about local government. Indeed, a lot of the submissions, there's a theme about local initiatives. Can you explain why you've put that in as a recommendation and why that emphasis?
Yeah, as I said, perhaps a little bit alluded to in my opening remarks, that one of the things that we're very concerned with at Australians for Mental Health are the big structural changes that government can take, government can make, that can have a flow-on, can sort of catalyse change. We find that in mental health across the board, there are lots of good programs and services and those responses that, in some cases are fantastic, should be scaled, should be better funded. But we really believe that until we start addressing sort of root causes and start building up new structures that drive new cultures, we won't get to a place where we can really make population-wide change. In the case of loneliness, it is a big abstract issue in many respects. Not to say that some of the programmatic responses aren't absolutely fantastic and should be supported, but we see the solution to loneliness being connection. And where does connection happen? It happens in community. Who is closest to community? Who primarily can influence what happens at community? We believe that's local government. And so we quite specifically think that local government should be tasked with identifying with its own area, within the sort of the idiosyncrasies of that area, recognising that what's good for Broken Hill isn't necessarily what's good for Bondi and vice versa, but recognising the prevalence of loneliness and identifying the opportunities a particular local government area has within its own jurisdiction to drive change. And that change could be anything. It could be found within existing budget allocations, just by sort of retooling those spends and identifying, and measuring their contribution to social inclusion. So whether that's a community centre or a sporting field or a community space or a public library, maybe it's some town planning decisions or town centre upgrades, things that perhaps are already within the spending regime of a local government area, but adding a lens that considers the opportunity to improve the data on loneliness, and then making local government accountable for that. So the Act requires local government to provide annual performance reports. We think that social inclusion and loneliness should be added to the Act as one of the specific areas where where local government is required to report its performance.
Thank you. And I note that both the submissions from Suicide Prevention and the Australian Association of Psychologists also talk about community-based programs, or I think one of them talks about, which I'm a bit intrigued about, community-driven data collection. So I wonder if I could go first to Suicide Prevention Australia, because you talk about community-based programs and interventions. If you could speak about those, but we'd really love also some examples of the programs that you think are working, and then we'll go on to the Australian psychologists.
Thank you. With the community interventions, a really important part about it is to make it relevant and to make it meaningful. So it's not a one size fits all. It is about drilling down to the interest groups. So, for example, men's sheds. Men's organisations where men can talk to men is a really valuable resource. Similarly, something that is youth-driven that helps engage youth. So there are a whole range of different ways that you can engage community. It could be through a more formal way, such as social prescribing, where you have referrals through to networks and even volunteer work, where you actually get that connection built. Or it could be through using examples with lived experience-driven community interventions, so that you're designing programs around what you know to be the risk factors, with the experience, so that you can actually build a very tailored, very effective and very meaningful connection for those people. Unfortunately, loneliness isn't something that just affects one demographic, so you're talking about multiple models, but that's part of the beauty of it, is that you can actually target it. We do have many members who run different services for different age groups. So, for example, we have members who target youth, and that can be it can actually be from anything from a social media driven kind of program through to a connection in person. So it's about finding the right platform for that demographic.
Okay, thank you. And Ms. Dober or Mrs. Curran?
I would agree with the previous statements by both members today that meaningful connections have to be intentionally planned. It's not necessarily a case of build it and they will come. And what I mean by that is a cafe opening in a rural area where people don't have the financial means to engage and to socialise won't be helpful. It must be fit for purpose. Co-design is really important, because if we actually look at the data of who is lonely, again, it is young men with young children, single dads with young children, they're very lonely, but single mums with young children are not so lonely. Single mums with older children are loneliness, so there is variance within the data. So I think co-design must be important, and I would also place a strong emphasis on urban blue and green spaces. Again, third places where people can come together and they don't have to spend money, because the data strongly tells us that financial concerns over the last 2 years are significant, and they're also impacting people's mental health. So it becomes quite a significant spiral. And then if we're thinking about data collection, currently the best tool we have for data collection about loneliness in Australia is the Household Income and Labour Dynamics HILDA survey. However, there is a stigma associated with being lonely or feeling loneliness. So I'm not too sure if we're fully capturing it in the way that we could.
Before I pass on to others' questions, I have a quick question about this issue of stigma, which I know you do draw out in your submission. We've seen, I think, you guys are the experts, but I think we've seen a reduction in stigma generally around mental health issues. And I know we've been clear that loneliness and mental health issues are not the same thing, but they're related. Why is it that you think that there's still stigma attached to loneliness when we've made such progress in other areas?
I think with stigma and mental health, we still have a long way to go, because some mental illnesses are more palatable than others. Complex mental illness is still not understood very well. And if we're thinking about loneliness, there is a social taboo with loneliness. The message that a person might feel who is lonely is that I'm not good enough, I'm not interesting enough, there must be something wrong with me. And so I think that is a cause and consequence of feeling lonely. So I think that influences and perpetuates stigma for many people.
Thank you.
I think, particularly young people who might have some financial barriers to inclusion. There's a lot of stigma around that as well, that I'm not the same, I'm different to my peers and I can't get involved in this because we've got no means to, join a soccer club or go to a particular social event. So there is a separateness and an additional stigma around social economic status there as well.
Thank you. Mr. Gambit,
Sorry,
Ms. Dober, and then I'll go to Mr. Gambit.
Sorry, I just also want to echo another point, gender as well. Men cannot necessarily share their emotional world to as much as they would like to. And so if we look at gender lines and gender divides, men and men over the ages of 55 are less likely to share that they are feeling lonely even when asked, and women are more likely to talk about that.
Thank you. Mr. Gambit, in your position for your organisation, that question about stigma being different, is there anything?
Yeah, look, I agree, and I agree with the comments that have been made. I think the thing about stigma is that there is perhaps it's more acceptable at a generalised level to talk about mental health and loneliness, more acceptable to and more required to start acknowledging that it exists, the prevalence of those issues. There is a more open conversation. I think those things are all true. I think that is a different thing to once we're talking about a particular individual in their particular circumstance, and how they are perceived by their network, whether that's their co-workers, their teachers, their fellow students, people in their families and sort of broader social networks. So how they are perceived within their own networks, but also how they feel about themselves in this context. So I don't think stigma is the only problem. I think shame is a really big problem. As others have alluded to, the shame of being somebody who is finding themselves lonely, particularly in a situation where you are surrounded by people. We need to disavow this sort of idea that a lonely person is a sort of Eleanor Rigby type character who's sitting at home by themselves. It is entirely possible to be alone in a crowd. It's entirely possible to be alone within a family environment, within a household, within a relationship. It's entirely possible to feel alone in the context of a busy life and a busy workplace. Those two things shouldn't be conflated.
Thank you. I might pass over to other questions.
No, Scott does.
Scott does, but Mr. Barrett.
Thank you very much. Mr. Gambian and Ms. W, you both mentioned, singled out the regional experience. Without asking too much questions, I might ask you both to sort of go into that in a little bit more detail. Why is that a particular concern, and what can be done to bridge the gap? And then I'll come to suicide prevention in a moment. But if you two could touch on that a bit more, that'd be great. Thank you.
Do you want to go ahead, Carly?
Okay, sure, thanks. I guess from a social infrastructure point of view, connection and public transport availability can be more difficult or very poor in rural and remote and regional areas. If we're comparing, say, urban New South Wales, there might be a bus every 10 minutes to half an hour. And for some towns, they don't have bus routes that take them to maybe where their friends, community members, family members are, or there are no bus routes at all. So I think infrastructure is really important to allow people the opportunity to actually be social if they would like to be social, because without that, it's very difficult. Not everyone drives, and Australia is a very car-dependent city. That cannot be the assumption, especially if we're talking about disabled people, young people, or just people who don't want to drive or don't have the means to drive, especially again in the context of the cost of living crisis where petrol is expensive. And then, of course, again, if we're thinking about geographical capabilities, some people are just more isolated geographically, and maybe community centres might have one opportunity for social interaction a week if they are funded enough, if they are funded adequately. But we're really thinking about the need for opportunity here, that need for being responsive to people's social needs.
Thank you, Mr. Gammon.
Yeah, I agree with all of that. Just simply the numbers in our limited research bear out that people who live in regional areas say that they are lacking connection more so than people within urban areas. But when you think about it and think about the types of scenarios that we might have, if you live in a small town and getting to see people, as Ms. Dober has rightly pointed out, requires transportation, and your closest relationships might be half an hour away or an hour away or 2 hours away, of course that's a limiting factor. If you don't have great access to communications like good mobile phone reception or good internet access, that's a limiting factor. If you live in a small town and your relationship ends, well, what do? Small towns famously are places where everybody knows everybody, and that can be a wonderful thing. It can also be a terrible thing when things go wrong. If you're living in the context of places like the far west in New South Wales, where we're talking about very, very small populations and very, very small groups of people that you can have face-to-face contact with, if you live in a place like Menindee or Wilcannia or Pooncarie or some of those places in the far west, how do you find your tribe? How do you find your people if your life circumstances placed you somewhere that is inconsistent with the type of community that you're trying to find? So I think we have, apart from the data that's showing that there's greater prevalence in the bush, I think we've got some really significant public policy challenges in those areas, and it's one of the reasons we think that it cannot be a one-size-fits-all proposition. We have to have solutions that are right for different communities at different times.
Thank you. Mr. Barrett, you said you had one more?
Yeah, sorry, can I just one other one, possibly to someone from suicide, to one of the others even. Look, we have seen, I've heard mentioned here today, men's sheds and soccer clubs. We have seen a drop in organisations, particularly since the late 70s and 80s to now, the number of organisations that are out there, as well as the number of people that are involved in those organisations. Keeping that in mind, and some of the things that I've seen in the suicide prevention, the submission, where there's the need to create more connection for people to have more friends. How do we do that, and how concerning is that decline in our associations and association membership?
That's a good point, a very good point. And a lot of the problem in the regional areas is access to services, whether they're formal ones or informal ones. Part of that is why we're asking for the first aid suicide prevention training, so that it is the connection. If somebody who is in a community leadership role, such as the barber, There doesn't have to be a connection, but if they're trained to be able to recognise distress, whether it's loneliness or suicidality, if they have access to this training, they can actually make that connection. They can say something meaningful. They can act in a way that will actually help that person. And it might be by providing a connection. It might be by guiding them through that situation until they're ready to make a connection. But it starts with an individual person. And if you equip the community through that individual, and then you build up through, that's how you create the groups, and it's how you create the connections, and it's how you can actually get those clubs back to support those people. Does that answer?
Yeah, it did. And I saw lots of nodding there as well. Sorry, for Mrs. Curran. Would you like to add to that?
I definitely agree with all of those points. We see a lot in like the construction industry. They're kind of leaders in this area of training up peers within the industry to be able to catch people, because it's those little moments where intervention can happen. Men of a certain age are very unlikely to go and see a psychologist, but they will, say something to their mate on the job site and be able to get some assistance there. So I think that peer-led mental health first aid training is really so important. With regards to like associations closing down and difficulties with getting enough of those community organisations as well, I think what we see happening is there's a big pressure on families to have two income earners if there's two parents. So we're seeing a lack of ability to volunteer in a lot of those community organisations. So funding those local level initiatives at a bit of a higher level might be a way to alleviate some of that, deterioration in the amount of services that are available. Local grants, community council grants, that sort of thing can go a long way.
Thank you.
Thank you.
Dr. Conn, did you?
Thank you. I do have a couple of questions. Thank you all so much for sharing your experience with us today. My first question was for the Association of Psychologists. I'm particularly interested in your submission and the role that you say that social media can play in facilitating meaningful interactions. And I suppose the context of us just having a conversation with the previous witness about how social media use can become harmful, or if used inappropriately can exacerbate loneliness. What are those ways that social media can be protective, or how could the government support social media to be used in a way that is constructive?
I'm not a social media expert, but I can say that the algorithms currently keep people on social media, and that can be a really helpful thing if you're vulnerable, if you are geographically isolated. But that does mean that some people might not go outside and connect in real life as much as they would like to. So I think there might be investment in meaningful local forums or groups that people can meet other people online, talk about mutual interests, and there can be perhaps joint meetups that occur on a recurring basis that might be free or very easy to access with different people and different cultures keeping in mind. So a social media kind of infrastructure, if that makes sense.
I think there's also a real value in social media based interactions for those with disability. So like we've got, meet up groups for people with illness done loss that happen. And so they're able to jump on and talk with peers if they're not able to access community. There's lots of interest groups based on those with chronic illness, like Spoonies is one that comes to mind. And there's also a lot of interest-based ones that someone who's autistic might be interested in joining. There are also some initiatives I've seen recently where interaction might start online and then transition to a in-person arrangement. There's a dad's group that I've seen recently where they were gaming online and then moved it to we're all in the same room gaming online. So it's helping people to engage and get connection, and then, if there's a possibility, moving that to an in-person arrangement where possible.
I was also interested in following up. The chair asked a great question about local government, which I'm particularly interested in as a former councillor, and I think one of the witnesses earlier mentioned the kind of role of urban planning, or actually having the right spaces. Could you go into a bit more detail about what that looks like?
I think when we're thinking about urban sprawl, Australia has a really interesting challenge ahead of us, and New South Wales is no different, with people fleeing to New South Wales to enjoy all the beautiful elements of being in New South Wales. However, that means that this rapid urban sprawl has led to suburbs and places where if you don't live there, you've got no reason to go and stop by. So we're needing to have urban blue and green spaces, because we know that this is really good for people's mental health. So places like public parks or lakes and wetlands that are rewilded, so that not only biodiversity can enjoy it, but also people, again, because these are things that are not come to no cost to the people who enjoy these spaces, but they also they invite interaction, these casual interactions where perhaps relationships and friendships can occur.
I'll ask a follow-up.
Yeah.
I'm also a member of the committee that's looking at the financial sustainability of local government, and certainly councils, and particularly rural and regional councils, are in really dire financial straits. So I guess as a devil's advocate, what do councils actually need to be able to do the kind of work that you're talking about, creating spaces for these interactions to happen?
Mr. Gambin, do you want to have a go at that, given your recommendation?
Look, I take the point that anything that gets proposed needs to be funded, and that's fair enough. But I'd make 2 points. One is that we are already spending a lot of public money on things that could be contributing to better social connection. Things like a local library. Now, these are already places that people come together, and they already deliver those programs. But imagine if the local library, in addition to providing its core service of making books available, had a KPI around its social inclusion. Imagine how that would culturally change the way the library is run. Imagine how that would change its strategic approach. Imagine how that would change what it chose to prioritise within its existing spending. The other, I think, great example is Meals on Wheels, where we know that it's a food delivery service, but it is also a source of connection for both the people who are receiving the food, who are isolated in their homes, but also the volunteers that are making the food. The connection that happens in the kitchen when the food's being prepared, and then in the warehouse where it's being packed, and then in the delivery process itself. So imagine if Meals on Wheels had a KPI that acknowledged what it's already doing, and it was recognised and supported for delivering that as well as it possibly can. Then there are just simple things that council can do that don't cost any money. About a decade ago, the then Marrickville Council just created a policy and a toolkit for locals who wanted to host a street party in their street to host a street party. It cost council no money. But it culturally sent the message that this is not something that we will allow you to do, it's something that we'll encourage you to do, and gave you an easy way to apply for the permits you need, and to deal with all of the regulatory barriers there might be to somebody who, a couple of neighbours that had the bright idea to host a street party in their community for Christmas or Easter or Australia Day or whatever they might choose to have a street party for. So a lot of these things don't need to cost a lot of money. Now, some of them will, of course. Let's not be naive. Some of these will cost money, and those funds should be made available. But in many cases, what we're talking about is making this stuff a priority and embedding that priority into the way decisions get made.
Thank you. That's a great example.
Did you have a question?
Yeah, I wanted to ask about social prescribing. Maybe you could just elaborate a bit more on this idea. And perhaps for medical practitioners, what are the barriers to social prescribing? And sort of a follow-up on that is, how can a medical practitioner or a health practitioner know what services are going to work?
Thank you. Social prescribing it's taking off in some parts of the world, such as UK, for example, but it is about connecting the community. So if somebody comes into a GP's surgery and is obviously lonely, obviously disconnected from society, and needs that help with reconnection, which that's the stage at which, if they can implement social prescribing, it's about putting them in connection with the most obvious network. So if there is a community that has a group, and this could be something that state government could help with, is compiling the networks and the lists, or local government can do, but it's having that access to that information. It might be a volunteering job. It might be somebody who feels that they've got too much time and they're lonely because they're sitting by themselves all day, every day, and they've got no way to make themselves feel useful, and they're disconnecting that way. So it might be about volunteering and creating a sense of service and value. It might be about something that is more mentally health based, where you have a child who has been bullied or that kind of thing. So it's a lot of the marginalised feeling people. So for example, coming back to the social media side of it, where you've got LGBTIQ communities who use social media, maybe social prescribing is good in that instance, where you can actually connect face to face. The social media might be the start of it, as somebody said before, but all of these different aspects of it all lead into the same thing of you need that reconnection. In our space, somebody who has lived experience of suicide often needs that help with reconnection too. It's an incredibly lonely time for many, many people, and that reconnection helps them to come back into community. In terms of the barriers for it, it is the network. It is knowing what's there. So that's what would need to be established. But there's nothing else that potentially could stop that from happening. And what you're doing is just reconnecting.
Sorry, Ms. Dober, I think you...
Ms. Dober, did you want to answer?
Oh, no, I was just saying I agree with everything that's come before, and I think some of the barriers are some GPs or health professionals don't know what they don't know. They don't know about this social prescribing movement as well, and it can also be based on what the person is genuinely interested in, what they used to enjoy, what they used to love before maybe something like mental or physical illness and their life upside down, or things like divorce or becoming a parent or aging.
Is there any evidence about, or any data about how much of this is occurring in Australia? Like, are GPs actively embracing this as an approach? Is it, the subject of discussion in GP group practices? Do we have any data on that?
It is emerging. I don't have specific numbers, but the Australasian or the Australian College of Lifestyle Medicine, they are a movement full of GPs that are all about lifestyle medication, lifestyle prescribing, and a big part of their work is about social prescribing and bringing that into all Australian GPs nationally. I don't have that paper or data on me right now, sorry.
Ms. McLaren-Jones?
Thank you very much to all our witnesses for coming today. I've got a couple of questions to everyone. The first one is a number of you referred to volunteering, and I'm interested to know whether or not, and we've seen volunteering drop over the years, particularly post-COVID, and also in, I suppose, younger generations. So I'm interested to hear from you about any suggestions you have to, I suppose, increase the uptake and interest in volunteering, particularly in light of the fact that the correlation between volunteering does address some of the issues that people raise around loneliness. So if you have any insights on that.
I think one of the things that I found clinically, and I don't have data to support this, is that volunteering is expensive. And in the cost of a living crisis, actually getting to a volunteer role when you have to pay for the bus or the train or sometimes, put petrol in the car, that is not something that some people can do anymore. So that has been one reason that volunteering has dropped. Another reason, particularly older teenagers, young adults, is that they can't afford to because they need to pick up shifts that they don't necessarily like engaging in, but that trying to juggle that and uni has become an all-encompassing issue. So I think if we're thinking of the cost of living crisis, how that is impacting rates of volunteering, I think that could be one issue.
Thank you.
I think as well there's a lack of information potentially around what opportunities are available, or the information is out there but it's not delivered in a way that's going to be seen easily by younger people. I think there's some research around the type of work and volunteer work that younger people are more likely to engage in, and I think the indications were that project-based opportunities rather than an opportunity that lasts forever is something that they're more likely to be attracted to. So perhaps thinking about if there are community organisations that need volunteers, maybe that's something for them to consider, that offering project-based or limited time opportunities might be a way to attract some more people in. And once people are engaged, they're more likely to stay.
I think volunteering can sometimes be one of those things that, on the face of it, you say, well, that makes all the sense in the world, doesn't it? People are lacking relationships. Where could you get some relationships and do some good? Volunteering is the obvious place. I think when you drill down a little bit and start thinking about where things aren't lining up, because on the one hand you say you've got a lot of lonely people and a lot of need for work that needs to be done, so why aren't those two things coming together? I think there's a couple of things going on. One is that, as has just been said, if you're working two jobs in order to pay your rent or pay your mortgage, doesn't leave too many hours in the day, doesn't leave mental space apart from anything else, to go and do a shift at the St Vincent de Paul or something. So that in itself, I think, is a huge barrier, particularly when you're talking about people with families and that sort of that juggle. On the other hand, and perhaps a slightly less obvious one, is that I think that for a lot of organisations, non-profits that benefit from having volunteers, the compliance environment that we're now placed in makes it really difficult to have volunteers or to attract volunteers. I remember years ago, I was invited to go and be on one of those food delivery services just for one night, just to get a sense of it and just to see how it worked, and I was more than happy to do that. But in order to do a couple of hours of handing sandwiches to people in a disadvantaged community, I was being asked to do a day's worth of training. The various regulatory requirements to go and hand somebody a Vegemite sandwich. These are I think we have, in the social services sector in particular, created, for very good reasons, I'm not criticising the rationale, we've created an environment where it has become very, very difficult for those organisations to kind of be responsive to where people are at and to create space for people where somebody can, on their own terms, just come and hang out. I think that's a barrier. I think another barrier is the volunteer organisations themselves and how they orient. Sometimes those organisations can be cliques. I think we all know examples in our own communities of organisations that, on the face of it, are wonderful community-based organisation, but we also know that they're cliques. And so I think a lot of the challenges we have around connection continue even within a volunteering space. And so I think tackling our ability to just have an honest conversation about that and to navigate what is disconnecting people, then I think that would go a long way. And to just chime in on that discussion a moment ago about social media, I think one of the things that social media is doing is eroding our ability as a community to relate to each other, because we're getting very curated content. Our phones are much more interesting than the more difficult conversations we might be part of. And so we're losing that skill. I think at a population level, we're losing the skill to connect.
Thank you. And just a final question, it's around funding and grants, and whether or not you have an opinion on the idea or the notion of a grant scheme where people can just apply for funding for different ideas and programs, initiative, versus a bit more of targeted investment with organisations. And I use examples, and it was mentioned before, about councils and councils taking more a proactive role in addressing loneliness from an inclusive point of view, but also neighbourhood centres. Where we saw, particularly during COVID, they were a point of contact, not just to assist with distribution of information and RATs, but also as a place to go to get information. So I suppose it's the view of whether it's better for government to be directing funds towards more targeted organisations versus the scattergun approach of grants. And if anyone has a view on that.
Yeah, I have a strong view about that, and that is, I think the best community centres are the ones that have block funding.
Yeah.
If you're a community centre, you might be called a community centre, but if all you're running is an aged care program, a disability program, and a childcare program, then that's all you're doing. That's all you are. The organisations that produce the best sort of community outcome are the ones that are funded to do community development, and we have less and less of that. We have less of that now than we've ever had, and I think that is a yawning gap right now in the sort of the makeup of our social services sector.
Thank you. Anyone online? Any comments?
If I could say, the beauty of targeted funding is that you actually get to have some meaningful aim in it. It's not a short-term nice project, and they might be really, really good, but a targeted one, you're actually getting to the meaning of why you're doing it, and you're also allowing the continuity, and that allows you to grow. So it's about ensuring that you've got the workforces within that funding who can actually skill increase, and they can share those skills with the people they're trying to help. It's about building on that work instead of doing a bit here and a bit here. So the more targeted that you can actually reach the audience you're trying to get, and then you build the skills around growing that audience.
Thank you. Thank you. If I could just go back to the submissions for a second of the Australian Association of Psychologists. And because I'm obviously at the moment reading all of these different submissions, I'm interested in how you identify a number of groups that are at increased risk of loneliness, but I'm interested in how you determined, what research you based your submission on, because reading different submissions, some research is saying age, gender doesn't matter. It's something that's felt across the board. Some are saying women, in particular cohorts of women. Some are saying young people. And yours is saying that men tend to be lonelier. So I'm just trying to give us a sort of base understanding of what evidence we're relying on for which parts, so that we can try and decipher that as well. So could
Absolutely. Yeah, I think it's tricky because loneliness is a normal human emotion. We all feel it at some stage. When we were developing our submission, I looked for peer-reviewed research. I looked for things that were specific to Australia, if New South Wales not specific. And then I went to big organisations such as the Australian Institute, who are a national non-partisan think tank who have incredible researchers, and the research you're talking about in particular is Dr. Michael Flood, who's amazing. He's very well known. So I tried to peer review, find Australian context, because loneliness is different across cultures and across countries, and then to localise it to New South Wales.
Okay, so you didn't undertake any empirical research. It was a peer-reviewed research, what was out there, try to essentially bring that to help us, synthesise that for us. Thank you.
Correct. Yes,
Thank
that's
you.
correct.
That's very helpful. I think Mr. Barrett has a question.
Yes, I do have one question for Ms. Trainer, who's been sitting there very diligently listening to all this. We've heard lots about the research and the theories of how we could fix this. I guess it was mentioned you have some lived experience that possibly could shed a lot of light to this. I just wondered in the last couple of minutes if you could just sort of respond to some of the things that have been said, and given the platform, what's something that you would like us to take home as a key message from this?
Thanks very much for that. And this is my first hearing, so hence why I've been quiet and observing. Look, I think the reality is when you've got a lived experience and you're, whether that be mental health, whether that be suicide, the reality is trying to reach out for support and trying to actually bridge that gap of loneliness is incredibly hard. The act of reaching out to a friend, the act of reaching out to a GP, the act of going to a coffee shop to have a coffee with somebody are incredibly challenging behaviours to engage in. And so I think when we're talking about what the context of a community can do or government can do, it's actually about what are the people and the support systems in the communities surrounding the individual. What can they do? How can we upskill them and support them in supporting those who are experiencing loneliness? I think a lot of the onus is often on the individual attempting to seek help. The reality is that we need to ensure that we're creating an environment that actually supports that, encourages that, and bridges that gap. So when we're talking about social prescribing, when we're talking about upskilling the community, we're really talking about how are we ensuring that we're creating more advocates and creating more, I suppose, diverse support systems that can bridge that loneliness gap. That's my 2 cents.
And just sorry, following on for that, I'm also going to presume that the longer you said it's difficult to reach out, I'm imagining the longer that the time before you do reach out would probably get exponentially harder to then reach out, suggesting the earlier that the intervention occurs, the better.
Absolutely. I think to a degree, yes, and I can only speak from my experience, and that's again when we look at those targeted interventions, recognising that everyone has a unique experience when it comes to loneliness, mental ill health, suicidality. I think the earlier, always the better. But the reality is that it needs to happen. We need to be equipped at any point, because yes, the longer that we go on or the longer you have that experience, the harder it can be to reach out for support, for connection. But that also doesn't diminish the reality of it. It's hard at whatever stage you're experiencing loneliness. And so I think it's also actually about advocating for ensuring that there's multiple opportunities at any point, and that we're not focused on just the end point of exacerbation where someone has been experiencing loneliness for their entire life or for years or months on end. But we're looking, so I think it is in part that, but also in part going, okay, how are we ensuring that we're creating ample opportunity at any point when someone is ready, able, or in need?
Thank you. I just have one last question. We've only got a couple of minutes left. Mr. Gambin, the submission of the Australians for Mental Health doesn't recommend a specialised minister in this space, which is counter to what we've seen in other jurisdictions and some of the other submissions. Very briefly, could you just explain that a bit?
Yeah, we really think that the answers here lie across the whole of government, and we're very concerned that by specifying a minister who may or may not end up with a department or any kind of enabling kind of bureaucracy around them, might direct responsibility really at that one person, rather than recognising the opportunity every minister has to deal with this issue. So in the same way that financial issues and any number of other sort of whole of government matters need to be addressed, overseen through central agencies, we say that this is the type of issue that every single minister has a role to play in trying to address, and that if coordination happens, it should happen out of a central agency, whether that's the Premier or the Treasurer or the Finance Minister.
Okay. Thank you very much. I think that's it, unless yes? Okay. So I just wanted to thank you all very much for your submissions and making the time to be with us today and answering so comprehensively our questions. I don't think anyone took anything on notice, but it may be that we do have supplementary questions for you following on from your submissions and your evidence, and the Secretariat will be in touch if that's the case. But again, thank you all very much for appearing today. We do appreciate it.
Thank you.
Thank you.
Thank you.
Thank you.
Okay, welcome to this afternoon's hearing, and we thank the witnesses for appearing. The first thing that I do, apart from, as I said, thanking you not only for being here today but for your submissions, is to ask each of you to state your name and position, title, and swear either an oath or an affirmation. And we might start with you, Ms. Clark.
So, Elizabeth Clark, I'm a partner at KPMG. And in terms of affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
I'm Martin Blake. I'm chairman of the Groundswell Foundation. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you.
Hello, I'm Johanna Pittman, the Chair of the Research Subcommittee of the Groundswell Foundation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And just before I get a statement, I just want to note that we do have the Honourable Scott Barrett online as well, and we'll be taking questions from online as well. Do you have a short opening statement? Thank
Yes.
you.
Elizabeth is going to start and then we're going to all say a few words if that's possible.
Thank you. So thank you for the opportunity to provide an opening statement. As I said, my name's Elizabeth Clark. I'm a partner at KPMG in our policy, economics and public impact team based here in Sydney. KPMG welcomes the opportunity to appear before the Standing Committee on Social Issues as a part of its inquiry into the prevalence, causes and impacts of loneliness in New South Wales. We commend the committee for their important work that will help policymakers better understand the issue of loneliness and hopefully pave the way for better solutions for our communities. I'd like to acknowledge the Minns government recognition of the issue and the potential for addressing loneliness to be a meaningful legacy for this government. As the committee is aware, Connections Matter is a report prepared by KPMG in collaboration with the Groundswell Foundation. It reveals the prevalence of loneliness in Australia. The results were stark. Loneliness impacts over 5 million Australians and is a significant risk factor for poor physical health, mental health problems and decreased quality of life. Our report found that 37% of young people are lonely. Lonely people have a 26% increased risk of death. The impacts of loneliness are equivalent to smoking 15 cigarettes a day or having 6 alcoholic drinks per day. And 54% of people are lonelier since COVID-19. Considering this, it's great to see policymakers now focusing on loneliness as a key health priority. It's also an economic priority. As the Connections Matter report found, loneliness has an annual healthcare cost to Australian economy of $2.7 billion, or approximately $1,565 per person per year. Mental health issues are closely related to loneliness, including depression. It's estimated to cost the economy over $60 billion annually. Given the economic and health impacts of loneliness, the Connection Matter report recommends 3 critical action areas. Firstly, collaboration. They're establishing clear policy directions across national, state and local levels to raise awareness of loneliness as a priority issue and taking targeted action. Secondly, communicate by activating stakeholders from public, private and not-for-profit organisations to embed loneliness as a priority issue into new and existing health and wellbeing activities. And finally, track progress by building the evidence base for loneliness and interventions in Australia through detailed and dedicated data collection, research and evaluation. Since KPMG's involvement with the Groundswell Foundation, they've done some great work to advance their thinking and refine their focus across those action areas, and Martin will speak to this shortly. We appreciate the opportunity to be here today. Thank you.
Thank you very much. Mr. Blake.
Thank you, Chair. In a world of always-on social media and digital connectedness, it almost seems inconceivable that loneliness could become a health crisis affecting 1 in 3 Australians. It's a health priority that has almost entirely been overlooked by health regulators and providers in Australia, and it's one that has certainly been exacerbated by the pandemic. I established the Groundswell Foundation 3 years ago to bring together a coalition of influential Australians to tackle the growing issue of loneliness and the impact on mental health in Australia. And we are truly delighted that the New South Wales Government has announced this parliamentary inquiry into loneliness. Our aim is to drive a groundswell of initiatives and action to eliminate loneliness. And as the committee would have heard, loneliness is a pervasive problem causing significant personal pain and detrimental economic and health consequences for society. The Groundswell Foundation and members of the reference group also share my sense of urgency to tackle the problem. Having seen the worsening data, personally feeling the impact of the pandemic and sustained use of phones and social media. In addition to traditional vulnerable communities, which are outlined in the Connections Matter report, we have an entire generation of young people that have a reduced capacity to create meaningful social connections. They are simply connected but disconnected. We have reviewed all the submissions to the inquiry and note many consistent themes, but unlike most organisations that made submissions, we're not specialists in any one aspect of loneliness, and we're not seeking funding to sustain or enhance our operations. In fact, in setting up the foundation, we won't be asking for $1 from any government in the world, and we're raising 50 million to positively impact loneliness, which we are well on track to do. What we're seeking is the New South Wales Government commitment to harness this moment, and for each member of the committee to recognise the singular opportunity to imprint your legacy on New South Wales society. As Minister Jackson reflected at a recent Rally Forever breakfast just in this very room, the inquiry needs to be a springboard for positive action. The loneliness epidemic is different from most public policy challenges, and we can elaborate on why that is. It is clear tackling loneliness requires an innovative approach that draws on other international best practices and initiatives globally. We just can't tinker at the margins. Our recommendations have one single goal: to ensure that change happens quickly and meaningfully. Our future depends on what we do today. Johanna is going to add a few remarks to that. Thank you.
Thank you. Ms. Pittman.
Thank you, Chair. As the chair of the research subcommittee for the Groundswell Foundation, we took on board that goal to ensure change happens quickly and meaningfully. And so with that in mind, if we could have 3 wishes, here's what we would look for. First, we'd want the New South Wales Government to create an enduring oversight body to coordinate and monitor initiatives to tackle loneliness. Second, we want to help roll out a public awareness campaign at the conclusion of this inquiry to signal the New South Wales Government's commitment to destigmatise loneliness. This recommendation has been made across and repeated in numerous submissions. But best of all, this would not need to cost the New South Wales Government any money. We have the creative talent and advertising industry poised and ready to contribute pro bono their expertise to make this important campaign happen. And finally, if we had one more wish granted, it would be for the New South Wales Government to acknowledge that this challenge is like no other public policy challenge we have faced. It requires a tapestry of solutions that are dynamically woven together. Some actions to tackle loneliness will influence the design of places. Some will be led by not-for-profits and community organisations. Some will be led by business and employers. And some actions will be around getting better data and research on the problem. Whatever the individual components, New South Wales Government will need to embrace experimental interventions, will need to be prepared to support a range of interventions without traditional constraints, and will need to coordinate across different entities that may or may not rely on government funding. And this is where we think the committee and New South Wales Government can establish a legacy. Through an enduring oversight body, the New South Wales Government could radically improve the well-being of its citizens and provide an exemplar for the rest of Australia and the world.
Thank you very much. And we'll go to questions. I have an opening one about you're looking at the effectiveness of interventions to tackle loneliness, particularly in youth, but I'm pretty sure you also note the difficulties in measuring efficacy. And so I wondered if you could talk a bit more about that, but also given those difficulties, have you still been able to glean any sense of the levels of efficacy across the types of interventions you categorise in your appendix? Direct support programs, activity-based programs, skill building. So we know that there's things are there. They're hard to measure. But given that, is there still anything you could tell us about it?
Well, I could maybe start off. In terms of my journey on this, I've really drawn upon the experience of the UK government, who've had a Minister for Loneliness, the inaugural Minister Tracy Crouch, for some 10 years. And essentially I made friends with the Department for Tackling Loneliness and Tracy and was able to glean those insights. The UK is the jurisdiction of the world that has most evidence on this, but unfortunately it is lacking. Most of the research on loneliness is what I would describe as enjoying the problem. There are this many people lonely, this cohort of people lonely, they're lonely because of X, Y, Z. And that's why we commissioned research with Melbourne University to look at what are the most effective interventions with young people in urban and rural areas. And yeah, that's currently underway. We will publish that in the first quarter of next year to inform policy decision making. Johanna might have some other remarks to make.
It is ongoing research that is underway there, and we're at the point where we are surveying a wide range of young people about those interventions. But in terms of the efficacy, there's a couple of things. One of the first things that we discovered was the range of interventions, and setting up that nomenclature for it is quite important to say, how do we distinguish all these different interventions? The second part is you can have the intervention, but how you get someone off the couch and taking up those interventions is just as important. So the intervention might be effective, but you can't get the people who need it most there. So that's the way we're looking at the two aspects of it. And so actually the follow-on piece of research is about barriers to taking up interventions. So it is a bit early to say. In fact, the survey we expect to have results in December. We'd be happy to share
That would be great.
emerging results as soon as they're available.
That would be great if you could take that on notice, and when they are, that would be extremely helpful. We appreciate that. Thank you. Maybe to Ms. Clark, we've had some questions and some discussion about loneliness being distinct from mental health. And I note in your submission you make that distinction, but in your introduction there seemed to be less of a distinction. I wondered if we could go back to your submission and you could explain a bit why you were so, it was so clear that you were making that distinction.
Yeah, I think, and the report articulates really clear definitions of loneliness specifically. So there is a lot of attention around mental health and mental health issues broadly, but I think what we're really focused on in this report is loneliness itself. And so we felt it was really important to clearly articulate that definition of loneliness up front and highlight the point of difference from broader mental health challenges, because it's different from a driver's point of view and a different from a policy response point of view. So that's why we felt important to kind of isolate that definition.
Okay, thank you.
I mean, if I can add to that,
Yes,
I mean,
absolutely.
essentially, every human being in the world has an expectation of the quality of relationships they'd like to have in their life, irrespective of age, gender, ethnicity. Now, what loneliness is the gap between those expectations and the reality, and that's why young people are disproportionately impacted by loneliness, because they spend so much of their time on mobile devices. They're connected but disconnected, and so that's why it's such an important issue. But loneliness is absolutely not mental health. It's not socialisation either. It's very specific, and in the Connections Matter report, it is quite clearly articulated. And I think there is a growing awareness around that.
Thank you for that. And you have mentioned social media, and again today already we've had some discussion around it with, ideas that it does enable some connection, but what about the quality of the connections? And I wondered if any of you or all of you could add a bit more around that. And I also note that in the KPMG submission there was also the idea of using AI and tech and how it might be harnessed in different ways. So if I can put that to you.
Do you want to talk about social media? Or?
Yeah, no, you can kick off if you like.
I mean,
Some specific
in the report, definitely we looked at social media and the fact that social media is almost a driver and a consequence of loneliness. So it can drive loneliness in the sense that you're not having meaningful connection. But what we also found in the report was that loneliness can actually cause problematic use of social media as well.
Okay, thank you.
I'd add to that it's not just the nature of the social media and how you use it for how it's being used, but particularly in young people, how it is causing them to lose that ability to have face-to-face interactions. And we've all seen that, and we see it in different degrees, but really anyone who's sort of grown up with a phone is going to have a reduced capacity to make those social connections in person unless they work on it. And so this is where sort of, rather than sort of seeing social media as the problem, it's seeing the deficit of face-to-face interactions as the problem. And maybe social media can be harnessed, and I know within the research on interventions we are looking at how important it is, particularly for specific subgroups, to connect virtually with people like them, and it's very important. But it's the absence of face-to-face connections that we can't overlook, and we sort of and to look at that positive side. How do you increase face-to-face connections to build those skills so that people can have that personal connection with others?
Thank you.
Another dimension to this is artificial intelligence. One of the businesses that I founded, which is based in London, is the leading business in the world to unobtrusively analyse corporate culture with the two leading professors in the world from London School of Economics. It's called Above Board. And AI is moving so fast, in fact it's doubling capability every 6 months. So in fact technology solutions, avatars, can be very helpful in providing companions for individuals, for old people, for young people, for different people in different groups, migrants, LGBTI, First Nations people, who all have mobile devices. So it's a double-edged sword, because, as Johanna said, it's really, in many cases, it's problematic, the extended use of social media, and it's fantastic that federally we've got some new direction in terms of use of social media with young people, but also it is an important part of the solution. Because certainly during COVID, during the pandemic, I certainly enjoyed connecting with friends all over the world, having Friday night drinks, and so it can really enhance connections. It is a double-edged sword, but it is sort of a little bit like a bushfire in summer. It's really a little bit out of control, and it's very reassuring to see the federal government's trying to put some freedom within boundaries and some clear boundaries around that.
Thank you for that. I have one more question, then I'll go to the committee. Groundswell in particular makes recommendation, or one of your recommendations is to support business-led initiatives. Can you talk us through some of those and what you've seen implemented and be successful? So I guess there's categories of what could be done, if we support this, what has been done and what has worked. That would be great.
So this is what I would describe as triple strength leadership. And this is combining the organisational and intellectual capabilities of the public service, of higher education and business. And we've worked very closely with Brand Black in terms of developing the initiatives within the Groundswell Foundation, the priorities. And we've certainly drawn on global expertise and experience in terms of successful initiatives. Certainly in Europe, specifically in the Netherlands, there have been some very successful initiatives around introducing slow queues into supermarkets, with the idea that many elderly people, the only time they get out of home is when they do their weekly shopping, and if they've got a automated electronic payment system, they don't have the opportunity to interact with anyone, and that's been enormously successful. I've certainly proposed to Bran that he promotes that within the Business Council Australia. Obviously we've got some challenges with the oligopoly that we've got in supermarkets, with many people charging at them with spears, and this would be a very effective way of positively contributing in the community to tackle loneliness and build trust in the community. What is very evident from the UK is the most effective interventions in loneliness are using the convening power of existing community assets to bring different cohorts of people together to make meaningful connections. Interestingly, the two most trusted institutions in communities in Australia are libraries and pharmacies. Now, libraries, in New South Wales we have 264 of them, and the New South Wales government have increased funding for libraries by 50% in the last 5 years. And under Mike Pratt's leadership, the former Treasury Secretary, who is a member of the reference group, they funded free Wi-Fi in those libraries, which has made the libraries a honeycomb for vulnerable people, for homeless people, for people suffering from domestic violence, migrants, LGBTI, different interest groups, youth groups, and to use the convening power of libraries in a different way to reimagine their role in the community to positively tackle loneliness, I think is an inspired thought. I'm certainly working with Caroline, the Chief Librarian, on initiatives. Pharmacies as well reimagined themselves during COVID, and that was principally because the pressure on the health system was so extreme that they got a mandate to engage in the community in different ways, particularly in terms of dispensing COVID vaccinations. But they are trusted in the community. There are 35,000 pharmacies, there are pharmacists, and there are 5,000 pharmacies. Now, one of the members of our reference group, Jenny, has got an initiative up with the Pharmacy Guild to run an education program with pharmacists which is accredited. They have points each year that they have to get. I think 30 learning points. This would contribute 10 learning points for strategies to identify and positively tackle loneliness and socialisation in communities. In the UK, one of the most successful things that they did was to have an alliance leadership pledge by the largest organisations across both the private sector and the public sector to positively tackle loneliness. And if you go to our website, I've written a short paper on what executives can do in the workplace to positively tackle loneliness. And then creating space within shopping centres to foster social connections. I live in Mosman, and they've got an initiative around chat, having a particular seat and table in cafes, so that they're for people to encourage people to chat and socialise. So that there are some really quite practical things that can be done in the community that are not going to cost the New South Wales government anything, but they have an extremely important role in providing that enduring oversight to understand the different initiatives, the effectiveness of those initiatives, and also where the gaps are.
Thank you very much, and I'll open up to the rest of the committee for questions. Dr. Conn?
Thanks so much for coming and for the very extensive submissions that you've made. The first question I wanted to ask was, in your written submission, you wrote quite a lot about leveraging place-based investment, and there's a particular comment about how planning policies can deliver greater connection and access to green space as well. Do you have any suggestions on how that should be done, or examples of where that's being done well?
Yeah, I think we've relied on the input from the Loneliness Lab in the UK, which has done a lot of research around how place can really be leveraged to design out loneliness instead of institutionalising loneliness. In terms of the specific planning policies, I think would need to look at there has been work done by the chief architect there, which has been really relevant, and looking at the specific rules. We note that the quality of green space is not the same as the quantity of green space, and the quality of shared community assets is not the same as the quality. So that's a sort of area in which the planning policy could incorporate that, but it's probably more in the field of expertise of the chief architect or someone within planning.
Which is more important, quality or quantity?
Certainly, I mean, from what we're seeing is that the quality of that. So, for example, the example is given that if you have a new development and they say it must have X meters of square meters of public green space, and so you could have some green space there, you could have a certain tree canopy, and you could have a swing set in there. That swing set is actually not going to be well used by young people. The space is therefore not designed for young people. It's also not really designed for old people. So how do you make sure that that same square meterage could be better designed, and you see that people have maybe a quiet area within a park, maybe a sort of a more communal gathering area. It's about how that public space is used, or that green space is used, versus saying that it's all created the same, and whether the planning policy could incorporate those sort of recommendations or best practice. That would be one area to look at.
Professor Thomas Astol-Burton is one of the members of our reference group, and he's recognised as being one of the leaders in the world in understanding the connection between green space, loneliness and mental health. And there are studies that he has undertaken, and also Professor Feng, around this. They talk a lot about what they call lonely-genic environments and green space, which is really associated with the social environments connected with space, and the ability to build meaningful connections within that space. And obviously, with the focus of both the federal government and all state governments around Australia on housing, and with the new legislation promoting medium density residential housing, particularly around transport hubs. This is a wonderful opportunity, but also a potential risk, because if not carefully managed by both the state government and the local councils, then we could actually institutionalise loneliness. And so this is a very real risk, but it is quite well documented in terms of the Connections Matter report. And, you know, yeah, Thomas Astel-Burton is a world leader on this. He's recognised as such, and his work in terms of the impact of nature. He talks about more trees, fewer tweets. It is really quite groundbreaking and fresh.
Thank you. My final one.
Did you have more?
We've got plenty of time. My second one's on a very different topic, so if you wanted to jump in on this, go ahead.
Well, I just wanted to, taking up that question about sort of third spaces, I mean, it strikes me, and we had evidence earlier that, you know, one of the advantages of third spaces is they're free, and that, in fact, this sort of suggests to me that perhaps loneliness is actually just a symptomatic of socio-economic disadvantage, that it's actually about class disadvantage in society, and that those who are socially more disadvantaged are obviously more vulnerable to experiencing loneliness. Would you like to offer some comments about that?
I'm on the cohorts.
Yeah, you come on.
So in the Connections Matter report, we highlighted, I think it was around 8 different cohorts, definitely who had a higher prevalence of loneliness. Definitely those who were of lower socioeconomic advantage were one of those cohorts, but they were one of many. So there was a large number of cohorts: young parents, young people, Aboriginal and Torres Strait Islander people. So there was a really large number of cohorts. So this is not just an issue for those who are economically disadvantaged. It is an issue for a really large number of cohorts of people. And I guess the responses for each of those cohorts needs to be targeted at those cohorts. So what you put in place to respond to loneliness for older people looks very different to new parents, looks very different to young people, for example.
I'd add that third spaces are the starting point. So if you have a third space that offers, it's how it's activated that really matters. So for example, and there was a submission made by Rally Forever. It's a very simple concept, but using the third space of a tennis court that, as you know, they're often not being used. It's bringing along volunteers to coach, provide free coaching. It's a weekly at the same time every week, and therefore it gives someone a routine. So that's a very different activation to something like in a library, which is a fantastic third space that might have a mahjong session or a kids reading session. Whatever it is, those activities, I think the key things to avoid the socioeconomic barriers would be, what are they costing for the individual, and are they targeted properly? So is mahjong happening in a place where people have an interest in mahjong, or and so getting that balance right in the activation of those third spaces is what's really important. And it could be a park with one yoga instructor that provides free yoga, every Wednesday lunchtime. It could be something very different, but it's how the third spaces are activated that makes, and then how that activation is communicated, how well people know about what's going on. You often see things where they're underutilised, and so making sure that it's activated and it's marketed to the right population groups. So a focus on third spaces is important, but there's those next 2 steps that are equally important.
Can I just step? Sorry, if you.
I was just going to say, interesting. The experience in the UK, they started off with this over a decade ago, with their initial campaign to tackle the stigma associated with loneliness, and they had a very broad campaign. And whilst it did raise some level of awareness, it wasn't that effective. What they've done is focused the campaign various campaigns. The campaign last year was called Let's Talk Loneliness, and it was specifically targeted at young people. And it was very effective in terms of targeting young people because it's much more specific in terms of those particular cohorts. I mean, all these initiatives that we talk about, they are very helpful, but there's no one initiative, there's no silver bullet solution, and that's why we're strongly encouraging you to think about creating this enduring oversight body, which really coordinates and monitors these initiatives, because you can look at the effectiveness of these initiatives and see what works and what doesn't work and what is helpful for different cohorts in the community.
Thank you. I might go to Mr. Barrett online.
Thank you very much. I was just thinking about, there's a lot of talk about these green spaces, and apologies I'm not in the room, I'm in Orange, which might give you some motivation for the line of questioning I'm about to go down. The green spaces you're talking about, I just wonder what impact drought might have on them and the flow-on effects through regional communities as far as social connectedness from drought.
Well, I think one of the very significant issues that's been surfaced in regional communities is transport and access to transport. And as transport services have been rationalised and improved, particularly an issue for older people in terms of mobility when they can't drive and things like that, to actually be able to travel around and meet with people, cohorts of people, and make those meaningful connections. I mean, droughts per se, I haven't really seen much data on droughts, but certainly where there's a crisis situation, that can be very helpful in drawing the community together in the immediacy of that crisis. And I think we've seen that happen very effectively in different communities across New South Wales and nationally. But it's actually the long tail to that in terms of where people were displaced, not living in their original dwellings because they may have lost their home through fire, or they may have problems economically with drought and the impact on the economics of the agriculture industry. So it's that displacement that can create an environment for loneliness to flourish.
If I can, if you'd like me to add, I mean, what I think many farming communities have seen is the impact of drought and the cyclical nature of farming has seen kind of an erosion of the profitability, leading to kind of aggregation of farms. So you've got less families because you've got larger farms, and where there might have been 5 families before, there's only 1, and so that's 5 less families in the community, so less opportunity for social engagement. So that's one of the consequences, I guess, of the economics of agriculture.
And rather than
I'll go for one more for you. One more for you, Mr. Barrett, and then we'll go to Dr. Conn.
Okay. Sorry. You sort of touched on it before, combining the green spaces with organised activities like yoga and that sort of stuff. Your types of interventions, you mentioned the activity-based programs like the sports leagues, volunteer groups, etc., etc. We've seen a massive decline in those clubs and organisations and also involvement in them. I just wonder what levers you think can be pulled to strengthen that activity-based program that could assist to, I guess, the earliest possible intervention as far as the decline into severe loneliness.
I think, and this is part of one of my key interest areas in the importance of participation in local activities through a public awareness campaign to say that social connections matter, they're good for your health, they're good for your well-being, they're good for your productivity. Through this sort of campaign that's saying, do you belong to as many organisations as your parents did? Do you, and the stats are you don't. Most of us belong to fewer organisations than the generation before. Through that awareness campaign to pose that question, but also to sort of have the resources to make what's available near you a bit more accessible. So one of the things we see is, I don't know where to start, I don't know what to go to. It's all finding these reasons why not to join. And so if we can destigmatize the fact, or actually just make people feel more motivated, they know why they need to participate, because they know it's good for their health, and they know, actually, I don't belong to many organisations. And then making, what organisations could I join? Maybe you're making that behaviour more likely to happen. But yeah, getting more people to join organisations and giving those organisations the young people to sustain their operations, because what we're also seeing is, if we think about a bowling club or great assets in the heart of town, often got a very ageing member base. And so how do you make those places more vibrant? You need more members. How do you get more members? You need people to know it's in their best interest to become a member, and there's actually broader benefits to it.
Thank you. Dr. Conn.
It's very related to what I was going to ask about.
Excellent.
So I suppose we've heard all morning about very structural and systemic barriers to people connecting. So whether it's physical environment, transport, cost of living pressures, families with both parents working, etc. So I'm really wanting to hone in on this suggestion of a public awareness campaign. The last question that was asked, the answer was that they were very effective at targeting people. My question is, is there evidence that an awareness campaign is actually effective at reducing loneliness, given that the kind of other systemic barriers? I suppose I'm interested if there is evidence of it working as a skeptic, that the missing piece of the public. I think people would love to join more sporting and community groups if they had time and access and income, etc.
In the UK, you can, they have a very disciplined process of reflecting on the goals that they've set and the effectiveness of the initiatives, both from the public service but also other organisations in the community tackle loneliness. And what they've found is that the campaign they've done to raise awareness around loneliness and specifically deal with the stigma associated with loneliness has been effective. That's on their website. But that's not dealing with loneliness per se. That's tackling the stigma associated with loneliness. But we're, to be honest with you, at ground zero. You've got, if I go to work and Johanna's my boss, and it's Monday morning, and I say, Johanna, look, I ring up and I say, I've had a tough weekend, we've got this going on with the family, there's some issues, I'm feeling really blue, then Johanna would absolutely support me in saying, well, here's the employee health line, have as much time as you like, and we'll check in with you in a day or two. And if I ring up Johanna and say, look, I've had a really tough weekend, I feel really lonely and I'm not coming into work today, well, that would have a very different reaction. And so there is a real stigma associated with that, particularly in young people, and there's really next to no support for young people in that. I'd strongly recommend you just dial into the UK and have a look at what they've done in terms of both the public awareness campaigns and the effectiveness of it. That is absolutely on their website.
Can I add to that in terms of measuring the effectiveness? I think it's always going to be one of many, and that's why I really like that sort of idea of a tapestry of solutions. It's attacking it at one level, and if we think about the Slip Slop Slap campaign, that was highly effective. There's been other awareness campaigns and we can't remember them, but there was the never quitting was the never try to stop smoking, so you could just keep trying to quit, and that was quite effective at that targeted group. We have to try something, because those campaigns have not happened so far. There's been mental health awareness raising campaigns, but we have to start, and we have to start by really saying, okay, which target group are we going to go after? I think whether it's a highly effective campaign or a moderately effective campaign kind of doesn't matter, because it's getting the ball rolling. and we're going to learn from that. And are we targeting the right group? Well, it's not going to be one and done. There will be multiple organisations, and that's certainly come out looking at the submissions, all the different vulnerable groups that we're talking about. For us, it's about youth that we're very passionate about because we see them as the productivity engine of the state, the country, and we see the increasing urgency around doing something there because the figures are only getting worse and the ability to make connections is reducing over time instead of getting better. So I think it's how effective it's going to be will depend on the quality of the creative concept that someone comes up with and the rollout, but we can measure it and improve on that. And I think what's really reassuring is that the advertising industry wants to contribute to that, and they're willing to provide that service, and I think that's a really important thing that we should harness.
Thank you, and unfortunately our time has ended. I think you did take on notice your research results, which we would love to have. If there is a further supplementary questions, the Secretariat will be in touch about that. We thank you very much again for your interest in this space, your submission, and being here today. Thank you so much.
Thank you. And I would encourage you to have a look at the Weekend Australian tomorrow because there's a special feature on loneliness.
Thank you. We will. Thank you so much. For joining us today. Before we begin, we'll get you to state your name, title, and swear an oath or an affirmation, and we'll start with Ms. Shaw.
I'm Elizabeth Shaw, CEO of Relationships Australia New South Wales, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Ms. Shaw. Dr. Hudson.
Dr. Stephanie Hodson, CEO of Relationships Australia, Canberra and Region. I solemnly and sincerely truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And Mr. Jennings.
Thank you. Greg Jennings, Chief Engagement Officer at Beyond Blue. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. And before I ask if you have short opening statements, I'll just acknowledge that we have a member of the committee, Scott Barrett, online with us who'll be asking questions as we get to that. But Ms. Shaw or Dr. Hodson, have you got a short statement?
Yes, thank you. Thank you, Chair, for the opportunity to appear before the committee. And we're both going to be speaking on behalf of Relationships Australia. So for our organisation, we witness the profound impact of loneliness every day, that we all know that it's a complex issue with far-reaching consequences for individuals and society. And it is marked by a lack of good enough relationships. People can be lonely and socially isolated, but equally they can be in relationships and experience intense loneliness. Research that we've carried out within our national network says that nearly a quarter of Australians report feeling lonely, and a figure that we're observing growing since 2022. Already vulnerable communities are at greater risk, including the elderly, unemployed, those in remote areas, called communities, members of the LGBTIQA+ community, and victim survivors of domestic and sexual violence. It's an obvious truth to state that the antidote to loneliness is social connection, and this is best demonstrated by the 85-year longitudinal Harvard study of adult development, which still continues today, which demonstrated that regardless of participant backgrounds, those with the strongest personal relationships were not only the happiest, but also enjoyed the best overall health and lived the longest. Strong social connections were demonstrated to provide emotional support, reduce stress, and increase feelings of happiness and belonging, which in turn has beneficial effects on physical health and promotes longer and healthier life. Equally, of course, poor relationships, separation and estrangement are inextricably linked with loneliness and are one of the key reasons for suicidal ideation. We all know that key transitions in life, such as leaving school, changing workplaces, relationship breakdown, moving interstate for work, having children, leaving the workforce, children leaving home, retirement, these life transitions all involve loss as much as they involve opportunity. Single parents, particularly single dads, experience higher rates of loneliness, for example. Those who manage transitions well will be able to hold on to and build connections to see themselves through. Not everyone can do this for a whole range of reasons. Relationships Australia's services therefore play a crucial role in supporting people facing the sort of issues that result in social isolation and loneliness. We've submitted a number of recommendations that are already before you about how to address the issues, but I just wanted to highlight three for opening purposes. So first of all, to speak to the whole issue of service design, which is about community and health services being designed around whoever is presenting as the symptom bearer as treated as relational beings, which goes well beyond just asking them, do you live at home? Do you have anyone in your life? But actually conceptualises them within that network and looks at how they can be part of the journey. So it involves all the audience of others, which could be family, friends, carers, workmates, who could be part of the service response, who are wise guides, people with good ideas and information, who may be part of the solution, but we know that carers themselves can be in higher need as well. So our community and the cost of community care will depend on people autonomously being able to move forward with their lives. So those familial and friendship networks, we rely on them as a community to carry forth the service once they are independent of the kind of organisations that, such as Relationships Australia. So just to give you a very quick vignette of this, for example, a young man in his 20s experiencing his first mental health crisis presented to his first community health appointment. His parents, who were key carers with whom he was living, attended with him, but they just sat outside the room while he was taken in, no role to play. At the end of the appointment, despite their fears about his well-being and safety and the role that they could effectively play, they were given a fact sheet and sent on their way to just drive him home, feeling very bereft about how they could have played a part. They were a sitting resource who could have been part of an action plan. Secondly, that we know that workforce is a big issue. What we would recommend is that every health and community service, as part of a multidisciplinary team, if not a core skill set, is that they are, say, couple and family workers or people who are trained in family intervention, as well as peer and lived experience workers who can forge connections, take people from one relationship to another. It's not enough to make a referral. We know that people fall down in the gaps. We need those who can be the handholders. And we also need those family workers to see the situation differently. Another quick example, a young woman with considerable gambling debt presented for assistance. She was given support around addictive behaviour, including financial advice. What is not unearthed until much later was her family, with great intentions, were taking their lonely daughter to gamble at the casino with good intentions to help her socialise, thinking we're taking her out and we're doing something together. When this was discovered, they came to a family appointment and talked about how to be a better support and how they could all potentially do things differently, but more importantly to focus on their worry, which is she had no friends, and we were able to help her therefore build her social network autonomously of the family. But it takes a family focused worker to even spot that and move to intervene. And finally, that funds need to be provided for the establishment of services that promote community connections, such as social hubs and peer support networks, and I heard your previous presenters referred to that. So we talk a lot about social prescribing, but we need to bear in mind that just making a recommendation or putting people in a room together is not always the end of the story. Not only we don't have enough services, but if someone is shy, in transition, lacking confidence, just have never built those social skills, being in a room with others can be an intensely lonely experience. We need to think about people requiring skill building so that they can make most use of those group activities. Otherwise, they actually could make them feel worse. We could measure attendance, but still not be measuring change to loneliness. So in order to look at some of these community hubs, we would also recommend the government's own commitment to fund community services to a minimum of 5-year contracts, because for people who are lonely, they need reliable supports that are there year in and year out. So we are very grateful to have our chance to talk about our particular angle in the issue of loneliness, and look forward to more questions from you.
Thank you very much. Mr. Jennings.
Thank you, Chair, and Beyond Blue, we thank the committee for recognising the serious public health risk that loneliness presents to people of New South Wales. The need for connection, the need to belong, is a basic psychological need. It's a foundational building block for mental health, and put simply, we cannot be mentally healthy while we're experiencing loneliness. The relationship between mental health and loneliness is twofold. First, loneliness is a cause of and a contributor to poorer mental health outcomes like anxiety, depression and suicidality. And second, experiencing a mental health condition can be, for many, a lonely and isolating experience. So loneliness is a key challenge for many people living with a mental health condition. At Beyond Blue, we are increasingly concerned about the prevalence of loneliness in the community. We recently commissioned a nationally representative survey that found 1 in 3 people stated they experienced distress due to loneliness over the past 12 months. And the impact of that experience were clear. People who felt lonely were over 1.5 times as likely to report anxiety compared to those who weren't lonely. They were nearly 2.5 times as likely to experience depression. And even more concerningly, lonely individuals were 5 times as likely to report suicidal thoughts and behaviours compared to those who weren't lonely. Data from the New South Wales Mental Health Commission also indicates that the inverse is true. People experiencing poor mental health are 4.4 times as likely to experience loneliness as those with moderate to good mental health. Loneliness and social isolation regularly feature as the reason people from New South Wales contact the Beyond Blue support service. We also know that loneliness and social isolation are significant contributors to many more calls from people who interact with our support service. So the evidence about loneliness is clear. It's prevalent and it's damaging. It's a complex problem that requires a comprehensive response, including action at the individual, community and social level. At the societal level, we support the development and implementation of a national strategy complemented by state-based approaches. And we're also excited by promising initiatives like social prescribing, and we support the call for a large-scale rollout of social prescribing, given some state-based trials are yielding really promising results. At the community level, it's critical that we continue to leverage existing initiatives to build social and emotional skills, both within individuals and in the settings in which they live, learn, work and play. So building social and emotional skills in those settings like workplaces, schools, local communities, local sporting clubs and in homes. And finally, for individuals, we recognise the need to promote social participation. So that might be things like organised sport or pro-social activities like volunteering, many of which are in decline. But for people who are experiencing persistent loneliness, or those people who are experiencing mental health conditions and are feeling alone, they would benefit from earlier access to effective supports. So things like the Beyond Blue support service, or digital initiatives like the Beyond Blue online peer support forums, which we've found can be really helpful at enhancing connection. So we know that loneliness is a major issue with significant health implications. The economic consequences are in the billions, and we strongly believe that an urgent response is required.
Thank you very much. Dr. Hodson, did you have anything to add, or that was the opening statement? Excellent. I didn't want you to think we hadn't considered. Could I ask a research question first of Ms. Shaw or Dr. Hodson? So in your submission, you indicate that there's further data from the 2024 Relationship Indicators projects that will be published in coming weeks. Is that available, and can we have it? Is there anything that's relevant for us?
It has actually shown that, yes, yeah,
Okay.
and we can actually now give it to you.
Excellent.
So the report was just so close to coming
Sure.
out, but we can actually provide you with the report.
That would be great.
The bottom line is the results have increased. So and especially those who say they strongly agree that they are lonely, there's been a 3% point increase in loneliness between 2022 and 2024. And that's particularly been in the emotional loneliness increase, in social and emotional loneliness. There was a slightly higher increase also in social isolation. So very happy to give you that report. And I think the other thing that's really important is, I think what's very valuable about that set of research, the relationship indicators talks a lot about who is it that you talk to. So who is it that who is your significant other that actually makes a big difference in your life? And I think from a whole of sort of thinking about relationships, it's men who seem to be the group that have the least people talking to them. So couples will tend to, 60% of couples will say it's my other couple, but then it's mothers and daughters that people talk to. And the last people that get talked to is actually, if you had a problem, you don't talk to you go and talk to your dad or your son. It's a very smaller group, which just goes to show the risk we have with young men and the risk we have with men as a society, which is also coming through in our suicide rates.
That's really interesting. I'm pretty sure it's in your submission that it did strike me that unpartnered men in particular
Yes.
were quite vulnerable. So thank you for that. And can I just confirm too, when you compared the data, is that actually a longitudinal study, or is that just the percentage comparison?
So we've actually replicated it. So the questions have been done 2 times.
But not with the same cohort?
No.
No. Okay. Sorry.
Same panel, so it's the same.
Yes, right.
Yeah.
Drawing from the same sample,
Yeah.
but not the same.
Not the same
longitudinal.
people.
Okay, thank you.
Yeah.
Sorry, we've got a lot of research, and so
Yeah.
we're trying to make sure I know which one's testing what. Thank you for that. Mr. Jennings, you noted the frequency, I guess, that loneliness or isolation is raised as an issue with your support service. What happens? When that's raised, what do your people do about it?
So we provide a brief intervention service. So if someone calls us, we support them with the feelings of loneliness that they're experiencing and any consequences of that as well in relation to their mental health, whether they're experiencing social anxiety, depression, low mood, or anything really. So our counsellors and coaches provide cognitive behavioural therapy or whatever interventions most suited to the client to support them through those feelings and to connect them into other supports that might be beneficial for them as well.
Okay, thank you very much. We heard a bit today about stigma and loneliness, and Mr. Jennings, your submission, or Beyond Blue's submission, really says that's quite a significant barrier to accessing support. 2 parts of that question. How have you determined that's a barrier? We've been talking about barriers as well. And what then are your recommendations to do about it to lower that stigma?
So look, stigma is absolutely an issue here, both in relation to help seeking, but also in relation to the way that people experience loneliness or mental health issues. What we are seeing and hearing is that while in relation to mental health, while there's greater awareness of mental health, certainly some aspects of stigma are actually on the rise. In particular, self-stigma. So a feeling of shame around your experience of a mental health condition is actually increasing according to our research. I know Ending Loneliness Together's research obviously found significant issues around stigma relating to loneliness. But what we're actually seeing is kind of cumulative stigma. So people will be experiencing stigma or shame around feeling lonely, or around, we see it around financial distress as well, and feeling stigma or shame around their mental health concerns, and so it kind of starts to build up and create a cumulative effect. So that self-stigma and that shame is something we are particularly concerned about. In relation to what can be done about that, we've found that normalising the experiences of loneliness or of mental health conditions is a really effective way of addressing stigma. So contact-based intervention, people sharing their experiences. And so at Beyond Blue, we have lived experience speakers who go out and share their stories of experiencing a mental health condition and their recovery journey to break down that stigma and normalise the experience of a mental health condition. And I know that loneliness, there's similar interventions around loneliness as well, sharing your experiences with others so they feel more likely to be able to open up themselves and seek support when they need it.
Thank you. And Ms. Shaw and Dr. Hodson, any responses to that stigma issue as a barrier?
Well, just to say that certainly to reinforce what Stephanie was saying is that we know that men are much more likely to go quiet than to speak up. There's some early research in my career that talked about women are 4 times more likely than men to have discussed their issue with a friend or someone else before presenting it to a therapist, and so they have more practice talking about issues and might have fielded those concerns earlier on. I think at the moment what we're hearing anecdotally from many clients, because we do a lot of work in the men's behaviour change space around domestic violence, is that men are more reluctant to come forward because they feel so implicated and the cause of everything. If there's a relationship breakdown, there's a stereotype, well, it would be the man who's let the relationship down, or might be targeted as perhaps a dangerous person. So we're at the moment hearing more men seeking services later and then feeling more worried about being judged from the beginning. All of those are very obvious barriers and are the sort of perverse outcome of the narratives that are in society at the moment, which are understandable but are not easy for help-seeking behaviour.
So what I would probably add is 100%. My background is as a psychologist working primarily with men, and one of the biggest challenges around whether it's loneliness or getting help is their own belief, their own self-stigma. I should be able to cope. We do have within our systems, though, touch points where people will come and touch. Whether it would be Relationships Australia is only just one part of the system where 1/3 of Australians actually, unfortunately, marriage will separate. So that is a touch point when we know they're going to suffer grief and loss, and it's a moment where there's a chance for an intervention. There's a chance to touch them. We do a lot of that sort of primary health work within the health system, and very much supportive of the recommendations by a number of agencies to say, loneliness should be something that is just like the GPs do a K10, which looks at anxiety and depression. We could be simply having a couple of questions which are about, and how are you feeling in terms of loneliness? So, we could be seeing this as part of our primary screening protocol, and my experience has been working with primarily military veterans and military populations. They're never going to put their hand up for help, so you've got to find those moments where you've already got a worker with them, and there's many workers in the system, so it could be someone going in to get a license, making sure that across the whole system, every time you might have something to do with New South Wales government, there might be that little brochure that's sitting there, or the sticker that's sitting there about have you made contact with someone today, or something like that. So I think it's got to be, if you want to get around the stigma, you've just got to have the touch points where people already come. We were listening earlier. I think the challenge always is, though, and I've done a lot of work where you've had the person that you're desperately trying to get them from your office as a psychologist to that support group. You want them, they've always kayaked, they've gone through a terrible part of their life, and they've stopped exercising, going out. I think lived experience, as Beyond Blue highlighted the ability for someone in the system to be able to, and Elizabeth said it too, to sometimes walk alongside, be able to be that peer support. So you don't want the peer supporter to go to kayaking for the next 20 years with that person, but sometimes it takes one person to get them from your office to actually the kayaking group. But the other piece in all this is so important is the micro skills. Not all of us know how to start a conversation. Not all of us know how to rock on up to someone. So the thing that happens in counselling is you teach a whole heap of micro skills, but then you don't get the chance to practice them. That's where social prescribing comes in. But sometimes you actually need to have in the fat in the system to have someone come and do the peer piece to get them person from where you are to where they could be. We do work in, I think it's really interesting too, because our churches don't have quite the same role they used to have. And so around Wagga, we work with the Presentation Sisters, a whole group of nuns who just went out in community and would help, especially older Australians, older members of New South Wales, actually get to events. And they, for the last few years, have actually subcontracted us just to provide some counsellors who could actually be out in the community with some of those lonely individuals and do some of that, get the person from where they are to get to the knitting group or to the cooking class. You don't stay there as much as my teams would love it. You actually go along and it's just making that connection and helping them do that warm transfer. What I'm very aware of is those groups are moving on too. Like that, those nuns are much, much older and they won't be there. And the work that they were doing in the community is no longer there the same way. So it's been a real eye-opener being in rural New South Wales and realising just there's some social glue that's not there anymore. And I think that's something that we should be really thinking about.
Thank you. I'll just ask one more question before I pass on to my colleagues, and that is about social prescribing. And you've mentioned it, but it also features in the Beyond Blue submission. And I note in the Beyond Blue submission you talk about the pilot in Queensland of social prescribing. I do have a question about what we know about efficacy, because one of the things when I'm listening to this is, well, yes, you can go to a doctor, you can include the questions in, I think it's the K10 question or whatever, but exactly that point, how do we know that that's actually translating into the activity that's being prescribed? So perhaps I'll start with Beyond Blue, because you do include that in your submission, that particular pilot. So if you could let us know what's been found, and then we'll...
Yeah, absolutely. So look, we have seen positive results from social prescribing trials, both internationally in the UK, in Queensland and in Victoria. There's some early promising results. Look, I think, Chair, you're right that more research is required, and social prescribing would benefit from further, high quality studies, randomised control trials, and ongoing monitoring and evaluation to ensure that they are achieving the outcome. Social prescribing is achieving the outcomes it is intended to achieve, both in terms of loneliness and then more broadly in terms of social participation, mental health and wellbeing, community cohesion, etc., etc. We have seen some of the early results from Queensland have indicated positive results in terms of loneliness, but not necessarily extending that to some of those broader issues. And the feedback that we've had from Victoria has been anecdotal so far, so haven't seen any published results in that space yet. But certainly internationally, we've seen some of these, the results of these studies published. So look, I think that it's promising, but we don't think it's a single solution here. We think it's part of a broader comprehensive solution, all of which need robust monitoring and evaluation to determine their efficacy and ongoing efficacy.
Thank you. Any response to that, or else?
Probably just in our submission there's the social campaign, which is Neighbours Every Day.
Oh yes, I wanted to ask about that.
Yeah, look, and it's done, we've just done a bit of a review with, it was with ANU in Queensland. So it is about with councils primarily, getting in with councils, creating events where people can actually go to them. Importantly, it's also about, my favourite one is the tips to achieving belonging, are those micro skills that I was talking about. So, you know, at these events, also having the opportunity to have those conversations with people. I know that in Canberra we did it at Girralang, and I know that the councils here out in rural New South Wales also do them. So it's a chance to bring people together in a fun way as a sort of family event. But while you're there, you actually tend to do some of that education. The work with Queensland and ANU actually showed, and we could give the committee the report, that it did reduce the levels of loneliness when compared with the general population. Those reduced levels of loneliness had a positive impacts on people's health, and it increased the quality of life. And I'm not going to pretend that I understand quality of life measures. However, the researchers identified the campaign cost about $4,000 per quality adjusted life years. And that's actually really good, because typically these sorts of measures cost about $28,000. So for a value of $4,000, you get really good outcomes. So there's actually been some of that. What is this value for money compared to some of the health interventions we could be doing?
Thank you. Thank you very much. Dr. Con, do you have a question?
Thank you. I had a very narrow question coming from the very broad questions that have been asked, but you covered most of what I was after with social prescribing. Relationships Australia, in your written submission, one of your recommendations was about ensuring that efforts to address loneliness complement gambling prevention strategies by ensuring the links between gambling and loneliness are well understood. Is that something you could expand on a bit more? What are the links between loneliness and gambling?
Well, I think what's really important is to look at what are the sorts of things that where people feel they can go out with a legitimate activity to join in with other people. And gambling, we know there's a whole lot of charges one gets out of that, including, you know, the idea that this might be hope over despair, or the sort of lucky moment, but it's also a certain amount of excitement. It's also something that even if you're very alone, you can go and sit with others and do. So there's a whole lot of draws on people psychologically to gamble. And there's also, as we know, we've all heard a lot about this in recent times, a lot of pursuit by gambling companies to sort of seduce, inveigle you to keep gambling. So there's a sense of being wanted and engaged. Now, a lot of that is coming from this might be my only activity, and they're ringing me up and saying they miss me, which is the kind of language that I've worked with gamblers who are having those sorts of calls. We want you back. We haven't seen you lately. So you can see that for the person who's vulnerable and perhaps living in an environment where they're still hoping, they're quite despairing of their social situation, it pulls on them in a whole range of ways. So it's an example of that. Any other addictive behaviour is also implicated, such as drinking for people who are lonely. That's that sort of thing. You can go and sit at a pub, have a drink by yourself, or you can drink alone at home. So I think we need to look at all the things that people do to make themselves feel better. And on the point of social prescribing, I think we've got to be very careful in our Western medical sort of conceptualisations of services, using a term like social prescribing, because we're used to other sorts of prescriptions. You know, it can just sound like someone makes a referral to the kayaking. So an organisation like us could say, well, we made 5 referrals, our job's done. But if the person has lost confidence till they've got there and they say, I know I should stop gambling, but it's the only activity I've got, we're going to have to ask more questions and understand people's experience. And we've got to be careful that a term like social prescribing doesn't become glib, doesn't become like we haven't stopped to really unpack it and understand it. And to bear in mind that the sort of services we'd like people to go, A, don't all exist, and B, people won't go if they haven't got the confidence. They'll know, I mean, they know often full well what they would like to do, what they'd prefer to do. We need to ask, what would you like to do and what would stop you doing that, which are the sort of things we need to get into. So it's always been my worry as a psychologist picking up a medical term like prescribing, because I don't know if we're thinking relationally about people's experience in the world. It could become another transaction that an expert does with a vulnerable person, as if their job is done, handing them a referral, off you go. It's not actually what you do with loneliness.
Another comment I'd make is there's just been a piece of research that's come out of ANU that is really looking at the fact that online gambling, I think for the first time ever, has reached 50%, if not gone over, being the most of the gambling harm in their particular piece of research. And what was concerning in that is like the young mums who are at home, who are socially isolated, and because gambling has now entered our personal spaces, entered our bedrooms, you're sitting there and you're all by yourself looking after the kids, it becomes easy to start to gamble. So I think there's a whole around our social media, the use of phones and online gambling, there's a real issue here around what it means for people who for whatever reason are not as connected. It might be a period of grief, it could be a period just because you're looking after the kids and you're at home by yourself. So that's where I know at ANU is doing some really interesting work in this space, and very happy to send the committee the reference.
Thank you.
Thank you very much. Oh, that's it? Okay. Mr. Barrett, have you got questions?
Yeah, thank you. I did have a line of questioning, but given there seems to be a certain level of regional expertise in the room, I might head down that path.
Go there.
I wonder, can we touch on, please, why there is a difference between regional and urban areas? And so I don't have to keep coming back, being out of the room. Some of the programs that have worked or you think could work in addressing loneliness specifically in regional communities.
Is that to any of us?
Yes, anyone.
Look,
Yes.
having worked in both metro and regional, I think the issue always is the ability to actually, if we're looking at workforce, if we're looking at interventions and workforce, as someone who, manages a Headspace and Wagga and trying to get support and services out to young, it's just so hard to get workforce out in our rural and regional areas. And I think that's having boots on the ground is tough in our regional and rural. And trying to get, we look after the South Coast a lot, and I do a lot of work down there. And again, trying to connect people and having boots on the ground to do community engagement activities is tough work because we're looking for workforces. And I'm going to be really honest, a lot of that's got to do with housing, trying to have enough housing. So even if I can find someone, I don't necessarily can actually find the person on the ground to be working with young people on the coast because we might not be able to have housing. So there's I think a very complex set of factors that make it hard to deliver community services actually in rural remote areas at the moment, especially around, how we pay our workforce, access for the workforce to be there. Having said that, I do see every single day amazing people that are there in those communities and doing this work, but they're very stretched, and often what we have got is people wanting to when I talk about doing that wraparound work, the work that when you see someone and you want to actually get them to the group, I think sometimes it is our more regional groups, my workforce, that would be more likely to give up their Sunday to take someone somewhere, but that's burning your workforce out as well. So I think sometimes we don't have as much capacity out there. I don't know if that helps at all, but that's some of the things I just face in trying to support, through a community service, getting services out to these groups. I must admit though, I will say this, is our workforce out in the regions are, the Henty Field Days, the ability to be at the shows, they're the first ones to volunteer to be out there on the ground, having these conversations with people, trying to break down stigma and, and volunteering to do the work that they can get out to the communities. But it is tough at the moment to have a big enough workforce to do even what we're already funded to do.
So just to add to that, we had a whole raft of services that we were providing around community resilience building in preparation for climate-related disasters. And what we were doing at a fairly cheap model, about $35,000 per LGA, so a substantial coverage, it was actually working with the community leaders to resource themselves. So it wasn't reliant, it's a different model, but it wasn't reliant on workers. It was reliant on workers to get this happening, but it was the communities themselves identifying local community leaders, which could be the local person who ran the school tuck shop, people who don't realise they're leaders, and building a community activity that the community themselves said they would value. So, we've got the stereotypical sausage sizzle, but whatever it was fixing the school hall, getting the community to rally around that and have conversations together on that activity. That was a way to bring people in, not because they had a mental health concern, but they might well have a mental health concern. And it was building the community up to be self-resourcing. Then the workers pulled out. Those are the sorts of models we could look at, but we can't say we're running a booth on loneliness, rock up, because they're not coming.
Yeah, thank you. Mr. Jennings, I see that you would like to contribute on this.
Yes, please. Thank you. So I think the Relationships Australia team have articulated some of the challenges, particularly around workforce, really well. So 3 points from me. Firstly, there is absolutely a need for and a benefit to these local place-based approaches to combating loneliness. And again, Relationships Australia have just articulated the benefit there of co-designing those with community to ensure that they're going to resonate with the community that you're delivering it in. And we're seeing that, in a variety of ways, including in relation to suicide prevention and suicide safe spaces, really co-designing those with community, in community, and being led by community. The second point is, we won't always have capacity to be everywhere. So complementing those local place-based approaches with more population-based digital programs can provide reach and scale that we may not otherwise be able to achieve by being in community. So ideally, you have a multi-pronged approach here, but digital offerings like online peer support forums, for example, provide access to a certain cohort in the community who will get benefit from it, while other cohorts will prefer those local place-based approaches. The third point is tying into our existing infrastructure right across Australia, including in regional Australia. So tying into schools to develop social and emotional learning skills early in life. So Relationships Australia referenced multiple times the importance of developing these skills, micro skills, social skills. The earlier we can do that in life, the better we equip children and young adults to practice social and emotional skills. So tying into schools, tying into workplaces, tying into other local community infrastructure that we already have to deliver some of those skills building and other interventions.
Thank you. Mr. Barrett, have you got another question?
I do. Can I just ask one more and then I'll
No, you can.
others, and if there's more time,
Yep.
I'm happy to fill that up.
Sure.
Mr. Jennings, you earlier, I'm pretty sure, lamented sort of the loss of or the decline of our community groups and organisations. I just wonder if you could talk more on why you think that's important and what role they can play, not necessarily once someone has become lonely, but in preventing that sort of slip down that pole.
Yeah, absolutely. Look, I think, again, to one of Relationships Australia's earlier points, social prescribing is all well and good if we have the avenues to prescribe or to point people towards meaningful, enjoyable activities where they can connect with others, build a community, build a sense of belonging. We have seen a decline in community participation in a variety of areas, in terms of volunteering, in terms of participation in local clubs, in terms of participation in religious activities, in political activities, in unions. So all of these formal organisations where people used to find a sense of belonging or a tribe, we're seeing participation rates decline. We absolutely see a role for those sorts of groups to provide that place where people can go to sense make, to find a sense of enjoyment, to find social support. But they need to obviously be prioritised, and people need to see the value in those groups that they can derive from those groups.
Thank you. You can carry on, Mr. Barrett.
Sure. So I wonder if someone could touch on maybe what this space might have looked like 30, 40 years ago, and why I presume that loneliness is increasing, why we're seeing that increase.
Well, I mean, I think the things that Greg was talking about, I think society has changed enormously, and there's a lot more individualistic ways that people live. I think the work has taken up a greater role in people's lives. So the time and the emphasis on life outside of work has changed. So a lot of space is taken up with work, and I think we see the stresses and the lengths people go to just about keeping themselves going economically. So I think what space you have left over for yourself, or even thinking about yourself and your mental health, it's a smaller space. And if we think of some of the past activities, such as the role church had, you were also compulsorily required to turn up to something once a week, whatever that religious activity might have been. So there were ways in which you fitted that in as a routine and as a requirement. And I think there's a lot of those sorts of things that were just built into how one lives that is quite different now. And we often talk about sport playing a role. There's an awful lot of people that don't play sport, have never played sport. So I think in Australia we overemphasise sport as a way forward. But I think what we're thinking about is what would be a team-based, what's a way people get together. And we have to start to think about community activities that speak to people's hearts and interests. And that's where we're seeing the emergence of other forms such as community gardens or volunteer effort of people looking after their neighbourhood, where they're turning up to work on the local school garden. A lot of those things which have purpose, meaning and results and their common activities seem to speak to people more now, but they need someone to lead. You need someone who has the idea to rally behind.
Mr. Jennings, I can see your hand up again.
Thank you. Look, I think Relationships Australia, Elizabeth's made a fantastic point there. The other point that I'd make is, particularly in recent years, the complexity of what the community is dealing with is really challenging. We're now at a time where it's extraordinarily volatile, uncertain, complex and ambiguous. And what we're seeing and what we're hearing, for example, in our support service, is people are approaching us around multiple and complex and compounding issues. And so using the cost of living crisis as an example at the moment, people are telling us that one of the first things they cut back on when they're experiencing financial distress is connecting with others. So they're retreating into themselves. That might be because they're embarrassed. That might be because they don't have the same financial means to connect and go and participate in activities. But they're telling us they're kind of withdrawing and looking much more insular than they have in the past. So I think one of the things that has certainly changed is just the really state of perma-crisis that we're all living through at the moment. It's kind of state of poly-crisis that we're all living through at the moment as well.
Just to add, we're seeing a much greater rate of loneliness with single parents and particularly single dads. And so, everything we've all just said, it's amplified for single parents who may have very few resources, don't always have family around them and are impoverished. But single dads in particular, I think, because there's such a limited, if not completely absent, cohort of peers that they might be able to relate to. But certainly in my practice, I see single mums who don't have anything left over emotionally, time-wise or financially, to do anything for themselves much as they would love to.
Could I jump in with a question there about risk factors, just because we're starting talking about particular cohorts again? In your submission, you talk about loneliness as a risk factor that increases vulnerability to abuse, for example, domestic violence, and you talk about victims of domestic and family and sexual violence are at higher risk of social isolation and loneliness. Can you talk us through the risk factors there?
Sorry, was that to us?
Yes,
certainly
please, that's from your submission.
Well, look, I think perhaps everyone would know that keeping a victim survivor isolated is a very common coercive behaviour in domestic violence. So if you also look at all the things that flow from that, which is not just about the control and isolation, but it's often a gradual erosion of the person's self-confidence, self-worth and their identity. So as they become both divorced from their social networks and also shamed perhaps with what's happening, even when they might leave the situation, they're cut off and shamed by what's happened. So just leaving the situation doesn't immediately open doors for recovery and confidence. So I think the whole cycle of abuse is in itself going to increase not just the isolation, but all the things that lead to that being a legitimate way to live, or an apparent argued as a legitimate way to live. And women particularly that are emerging from that can take years to recover their sense of self. And we also see this after relationship breakdown, generally, not to dismiss the effect of violence, which is staggeringly significant, is also for a lot of people their confidence is really rocked about their worth, their lovability, their place in the world. A lot of people do still feel shamed by separation and divorce itself, let alone violence. You would think it's so ubiquitous, the amount of separation and divorce, but for many people in more conservative communities, but more broadly, I think relationship breakdown and all its consequences can have very significant ramifications for children and for adults.
Thank you. Sorry, Mr. Barrett, I cut you off. Did you have other questions?
Yeah, I can certainly keep going. I do have another question, but I think you led to one there that I might pick up on something Mr. Biadam said before. And when these children are seeing that loneliness and experiencing that, I guess, as a family, what impacts does that have on that child as they grow and develop?
Was that to you, Greg? Sorry. Who are you?
I'm sorry. I think you were just sort of talking about the impact this is having on children.
Yeah. Look,
the
absolutely.
children living in this.
Well, if you think about how children are living with violence, often the sense that we don't tell anybody what's happening in the house, we can't bring anyone home, I cover up. Children learn to cover up what's happening as well. So after a while, their ability to just openly connect with friends is limited as well. If children are living with an isolated and lonely parent who maybe, for a variety of reasons, doesn't have social connections, doesn't pursue them or is afraid of them, they're not always enthusiastically encouraging their children to have those skills or know how to offer skills for them. So the whole family unit can become very isolated and also almost become each other's friends and social support. So that can be a very collusive and limiting experience in itself. So what you find is if you have a parent with mental health vulnerability, then the children or the carers around them, whether they are children or older parents, tend to be implicated around their mental health as well, and their world, the world of the whole social group can get smaller.
So one of the things to think about then is one of the most powerful programs we find is programs like we have one called Women's Choice and Change, which comes out of particularly Elizabeth's team actually developed. It is about bringing women together and then learning skills together. So some of these group programs, whilst group programs are harder to do, they take a little bit more resource. They are inherently able to, if you can be with other people who've got the same experience, you don't feel so alone anymore. So we do find very powerful the group programs, whether it's men, because we do have men who want to change, and we have men who then form a group and will actually support each other. So I think there's a lot to be said for thinking about what are the programs, and Elizabeth and I were talking about this before we came in. There are programs where if you said come in for a program to deal with the loneliness, you're less likely to have the people come in than if you put together a program that's about be the best parent that you can. And in reality, what we're doing is teaching those micro skills. We're teaching, helping them deal maybe with their own intergenerational traumas, and then getting them, helping the next generation actually do better. So we're there's a whole piece in there around really good focus on especially young parents and bringing them together. I've done couples groups that one of the nicest things that ever happened to me as a psychologist was to years later be sent a photo. There'd been a couples group and they'd only spent like 6 weeks together, all these couples sorting out their issues together, but they felt less lonely because they all were in the same boat. They went up to Thredbo and they used to have a gathering, and they'd been having that gathering for 30 years. So that formed a social group that no one else could actually understand because they'd gone through a similar experience. So there's a lot to be thinking about these group programs where we bring people together with similar needs, and whether it's a vulnerable group in a community, parents that need to learn at the same stage together. We all know that mums who go to play groups together sometimes form lifelong friendships. So it's really sometimes it's about having these opportunities. It's sort of where we started. Where are the natural touch points where you put that extra bit of effort in, because group work is harder, but group work also forms friendship groups that can last decades.
Yeah, I think just to really emphasise, like we're about to start a new dads group. Well, you see, that group of dads might be the only time they've ever sat and talked together, and they'll come to a new dads group. They wouldn't come to a loneliness group. Family life, there's lots of opportunities where you can get people in about the topic that's perfectly normal and understandable to turn up for.
And not stigmatised.
Not stigmatised, and the secondary gain is the connections, yeah.
Thank you. Mr. Barrett?
It's almost like camouflage mental health support.
It really is.
The other point I just wanted to make, Mr. Jennings, talking about the clubs and the organisation, and I will come back, Ms. Shaw, I certainly don't mean just footy clubs and sports clubs, crochet clubs, whatever they might be. I wonder also if there's the once removed benefit, if a group of people are together talking about their community and they say, gee, have you seen Greg for a while? He sort of started to drop out a bit. That has an impact for that person as well. So it's not just the members of those clubs and organisations that benefit, but other people they know. So there's sort of that once removed benefit for the community and for loneliness.
I think absolutely. The ripple effects of those sorts of groups and the connections that are formed can't be underestimated. So that is a really positive side effect of those sorts of groups and clubs coming together. They form communities and they give people a chance to practice social skills, which then they take into other aspects of their life, and the positive impacts continue to ripple out. So I think that is why they are such a valuable avenue to promoting social connection, and as you mentioned, a source of social support. So that is again something that can't be underestimated. We know that before someone speaks to their GPs, before they call the Beyond Blue support service, people are most likely to turn to family and friends in times of need, if they're struggling with their mental health, if they're dealing with a life stressor. And so having those helpful support networks is so critical for our mental well-being.
I should note too that groups are a really comparatively cheap intervention. Compared to one-on-one work, groups are really good bang for buck. You have more people in it who might actually say, let's keep meeting on our own, so they're autonomous of us. We've currently got 700 on our waiting list for group programs. We don't have enough funding to actually run them, but that's how appealing they are. That's a hell of a lot of people that could be connected to each other if only we could have the resources. So they're very appealing and very worthwhile and value for money.
Thank you. We are at the end of our time for today. I want to thank you all for coming and for your submissions. Also, you kindly took some things on notice that you will provide for us. The Secretariat will be in touch about that, and if there's any supplementary questions. But again, thank you so much. Thank you, Mr. Jennings, as well, for being involved. Thank you.
Is it okay for me to take a photo? Do you mind me?
Thank you. Someone might not have their mute on in the background there. So welcome to the afternoon session of the hearing today. What I'll get you to do is introduce yourself and your position and swear either an oath or an affirmation. And I might start in the room with Dr. Kong.
Thank you so much for the opportunity to appear today. My name is Dr. Nancy Kong. I'm a senior lecturer in health economics at the Center for Health Economic Research and Evaluation at the University of Technology, Sydney. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you so much. Dr. Vu, would you like to introduce yourself and swear an oath or affirmation? Thank you.
Yeah, good afternoon, everyone. My name is Lee Lon Vo from Curtin University, Bankwest Curtin Economics Center. I am a research fellow. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Thank you. And Mr. Twomey.
Good afternoon. My name's Chris Toomey. I'm a Senior Industry Fellow with Bankwest Curtin Economics Centre at Curtin University. I also work as Leader of Policy and Research for the West Australian Council of Social Service, and I solemnly, sincerely and truly declare and affirm the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. Thanks.
Thank you. And before we begin with questions, would you like to give a short opening statement? Dr. Kong?
Sure, yeah. So over the past 7 years, I've been actively engaged in academic research focused on the social economics of health, social economic determinants of health, particularly pay attention to the economic well-being among vulnerable population. So my co-author and I have conducted a research trying to better understand the relationship between loneliness and physical isolation, such as living under lockdown and rarely seeing each other. So we find that being alone does not equal being lonely, except for those who are young adults and those who are extroverts. So how we did this, we used the longitudinal data, national representative panel data from household income and labor dynamics in Australia that tracked more than 17,000 Australians. So every year I ask the same question from 1 to 7, how do you rate the following statement, which is, I often feel very lonely. So tracking the same people over time could help us understand changes in circumstance would affect how that would affect the feelings of loneliness. So we compared those changes in loneliness levels within individual between those who experienced extended lockdowns and those who had experienced little to no lockdown. So what we find is that physical isolation, represented by the number of lockdown days experienced by each individual, did not significantly affect loneliness. So we account for many factors such as working from home, health status, job industry, household composition, dwelling types, and things like that. And those, including those factors, do not change our results. We also looked at the long-term effects and find that 2 years after the COVID lockdown, things still, like loneliness level is still quite stable. So we also wanted to find that how this relationship could be kind of changed according to which population group, including different income, age, gender, ethnicity, personality, living arrangement, and remoteness groups. And what we find is that young people and extroverts do experience a heightened loneliness level. So this kind of call for targeted policy towards this population. We also looked at how people may anchor their feelings to their friends and families that who do not experience lockdown, and we do not find that those who live closer to the borders, that is, have more friends next to those neighbors that are not currently in lockdown, this distance does not matter. So meaning that the people do not anchor their feelings of loneliness according to their peers' experience. So those are the kind of like non-results findings, but we do find that people who have higher community satisfaction, those who experience, or those who stay in touch with friends and family more, have lower level of loneliness. Interestingly is that merely having the access to internet does not reduce loneliness. It's how you use the internet. So we looked at how during lockdown, people do spend more time doing household chores, playing with kids, and spending less time commuting or running errands. So those factors increases the relationship satisfaction and could explain how loneliness does not actually increase during lockdown. So in the end, our study challenged the idea of being alone and being lonely are the same thing. And we found social interaction and a support network are crucial. So this is my opening statement.
Thank you very much. Mr. Toomey or Dr. Vu, would either of you like to do a short introduction?
Yes, we've agreed I'll make a brief statement on behalf of both of us. I'll keep it short so we can go to questions. Our submission to the committee was based on our 2021 report, Stronger Together, Loneliness and Social Connectedness in Australia, which looked at trends in social connectedness and assessed their implications for development and well-being. The timing of our report meant that we were one of the first who were able to actually look at the impacts of COVID-19 on people's sense of connectedness, their social capital, sense of identity, solidarity, trust and belonging. Not surprisingly, the largest states, Victoria and New South Wales, had the greatest declines in social contact, and these were linked to declines in life satisfaction and increased loneliness. One of the particular things that stood out were that there were particular cohorts of groups who are in the community who are at greatest risk of loneliness and isolation. So we looked at what were the drivers of loneliness and what were some of the factors that can mitigate it and how that can add to our resilience and sense of inclusion. One of the things that stood out was young people aged 15 to 24 were the most at risk and showed the greatest decline in their social connectedness. Interestingly, the decline was strongest in young men. However, we also saw during COVID it was young women who reported that social isolation from their friends and family was the most difficult thing. Both of those findings sit on top of a much longer trend that we've seen in declining wellbeing and sense of belonging among young people, both in Australia and also internationally over the last decade or more. But we then saw particularly the impacts of isolation during COVID then kind of tended to boost that. So one of the things that we're looking to in the future is to do some follow-up research to actually see how the COVID recovery process has gone, how well people have bounced back, and really to look at what are the factors that have helped people to recover versus those that have tended to get a bit more stuck. One of the other things that came up quite strongly was the vulnerability of people who were particularly experiencing life transitions. So you've got young children starting school, one at-risk group, young people who are, moving from school to work are another group who are at great risk. Other factors that stood out strongly was poverty contributes to social isolation, and those in the lowest income decile were more than twice as likely to report being lonely. There are also strong links going both ways between poor health and loneliness. Both people with poor health and those living with a disability are more likely to be isolated, and that contributes to worse wellbeing outcomes. But we also found those that were lonely are also likely to be less healthy, and that loneliness tended to contribute to people not looking after themselves as much and more likely to undertake risky health behaviours like drinking, not exercising, smoking, eating badly. One of the things we highlighted in our report was we did some analysis around the economic cost of loneliness. We estimated that as coming in at around 2.7 billion per year, or an average of 1,565 per year for each person who became lonely. That was at a national level. Pro rata, based on population, for New South Wales, that would have been around $848 million per year. We looked at some of the impacts around technology and social media. One of the things that the results suggest that the impacts can vary, but that social media is less helpful for young people who are already feeling lonely. And again, this is one of these issues that's really important for us to revisit to see how things have emerged. It's probably worth having a look at the work that we did in there around developing a social connected index, and it kind of highlighted 4 different domains that interacted. Social interactions, which is contact with friends, family and community. Social support, which is actually people that you can feel you can lean on and confide in. Your sense of interpersonal trust for those around you and in your community. And then also socioeconomic advantage also had a big influence on people's ability to do things and get out and to get connected. So that's pretty much it. The other thing I did wanted to acknowledge just in passing, I noted that you'd also had evidence from Professor Michelle Lim. I just wanted to acknowledge the great work that she's done with End Loneliness Together and endorse the work that they've been doing. It's very clear that she's been a leader in this field internationally, and so, we continue to follow her work and look forward to working with her. But I think that's it. We're happy to go to questions. And
Thanks very much. Thank you very much for that introduction as well. I wondered if there are a couple of questions just about the actual research sort of method itself, if that's okay to start with. Just with regards to your focus on the state series, was that self-reported? Was there a validated scale that you used? What was the method for that? That's for Bank West Curtin crew.
do you want to talk to that, Lily?
Sorry, my signal is not good. So can I, just briefly repeat the question? So it's about state series, and then what's the question, please?
I just wanted to know your methodology. Did you use a validated scale? Was it self-report?
So about we basically in the report we use data from the HILDA survey, which is the Household Income Labour Dynamics in Australia survey, and we use the data from 2001 until 2019, and this is the nationally representative survey. So we got observation from the whole country, and then we also use a sampling weight to estimate kind of like represent measure of loneliness for the whole country as well as for the state as well. And in terms of the measure of loneliness, so there is a particular question in the survey asking the respondents that how often do you feel very lonely? And the responses ranging from 1 indicating strongly disagree to 7 indicating strongly agree. So the individual are considered as very lonely if they selected numbers 6, 5, 6, and 7. So that's how we measure loneliness in the survey and how we deal with the sample.
Okay, so it was a HILDA analysis using HILDA's sample and HILDA's methodology. There wasn't a separate validated scale or self-reports in you were using existing data, which is the same as Dr. Kong, who spoke earlier. Okay, thank you for that. That wasn't particularly clear. But while we're on that, Dr. Kong, if I could just ask, I think in your submission you talk about other data and scales that would be better to use. I wonder if you could just explain a bit about that. And is there any research in Australia that has used those things? Because the Hilda stuff, which is widely available, but hasn't been developed specifically for this, I guess.
No.
So can you give us a sense of what else is there?
Yeah, so I have to say that I'm not like the expert on this, but like I did looked up some papers for this question. So basically, so in my submission, I cited a paper, May's 2022, talked about the measurement of loneliness. So the loneliness is kind of widely defined as the when people perceive a discrepancy between the actual and desired social relationships. So usually you would measure what's the actual, what's the perceived. So in this paper, they evaluate, I think, 8 different scales. So not just one single measure as Hilda, but like 8 or 10 questions. And those questions usually cover emotional and social loneliness items. Emotional is like what you perceive like network. Social is what you perceive network, while emotional is like internal, like how you feel. So what they find strikingly is that most of the scales, or like more than half of the items, are not actually about this discrepancy between the perceived and actual. So I think what they suggest is quite new research, is talking about we needed to update to make it better. In terms of in Australia, whether we have this or not, so my co-author Jack Lamb, who's done a lot of loneliness research, he is a sociologist, whereas I'm an economist. So I believe he has used some other loneliness scales that is not from Hilda, but also like just using like a first-hand data where he actually collect the data himself.
Okay. Relatedly, and this might go to Bankwest as well, just as more as researchers than your actual submission, because I think, Dr. Kong, your submission, you talk about the need for ensuring cultural and demographic relevance, because we get these surveys, we get this information, but is any of this sort of sensitive to different demographic or cultural needs or interpretations? So when we get, you can start first if you like.
Okay. So in my research, because I was particularly looking at how physical isolation impact loneliness, and I did look for like whether immigrants versus non-immigrants, and those who are native speaking, like English is the native language versus they're not. And I did not find particular difference, but that's specific to physical isolation. What I did read is Curtin's submission, which I think they have done more on the origin of the country, and I really enjoyed the graph as well. So I think I'll defer this question to them.
Thank you. Curtin?
Chris, you want me to go first?
Yes, you can go first if you like.
Yeah. Hilda is very rich data set, and then include information on the country of birth of the respondents. So we use that information to identify where they're from, and then we compare the prevalence of loneliness among different people coming from different countries. And then we found that people coming from, for example, from the culturally groups different from Australia, for example, Asia, Africa, or Middle East, are particularly at risk of social isolation and loneliness compared to, people coming from UK or New Zealand, or people Australian, born in Australia. So that from the report.
Thank you.
Yeah.
Mr. Toomey?
Just a couple of quick comments, if it's helpful. First, going back to your previous question, in terms of someone developing particular survey or particular scales, Michelle Lim has done that work, and she's both had one robust question that can be put into other surveys, plus a scale with several questions that kind of digs around the issues.
Thank you, that's helpful, thank you.
Coming to the cultural issues, One of the things that we didn't look at in the research but came up in some of the discussions that we've then had afterwards with key stakeholders has been particularly around the links to community, culture and land when it comes to First Nations, and the experience of being isolated and being off country, kind of from what we've been told anecdotally, is something we want to look into, because people say that that really impacts on their well-being and hence their sense of connectedness and belonging. So I think that's a really important issue to consider.
Thank you very much. I've got more questions, but I'll pass over to my colleagues and we can come back. Dr. Conn.
Thanks. For Crichton, I was really interested in your written submission, which was really extensive, thank you, in the number of submissions that you made around reducing poverty, and interested if you could speak to the connections that you found between poverty and loneliness.
Yeah. Mr. Toomey or Dr. Liu?
Chris, do you want to go first?
Yeah, look, I'm happy to jump in there. It was one of the things that did come through quite strongly. And so, yes, I mean, a number of things that look like we ended up putting in 4 or 5 different recommendations in response to it. Certainly one of the key factors simply came down to people not having the resources to feel like they could get out and engage. This also comes through very strongly in a lot of the interviews with young people when they talk about not having the resources to participate when it comes to school or social activities. One of the other things that we were then concerned about was kind of the interactions that you had between poverty, loneliness, and then health and well-being, and kind of the cumulative impacts of that. I'm just having a look around to try and see. I know that we had a very good section on that. Have you got stuff you want to jump in with there, Lily?
Yeah, thank you, Chris. In terms of the association between poverty and loneliness, we found that the people from lowest income decile are more than twice as likely to report being very lonely compared to those people in the highest income decile. And the loneliness gap between the richest and the poorest remains significant even when we control for all the other factors. So imagine that we just compare between identical populations. So all the other characteristics like education, family structures, all things like that are identical. And so we just compare between people with low income and high income. And we found that people with low income are much more likely to feel lonely compared to people in the high income. And we also found that single parents are more likely to feel very lonely compared to the other family structure. For example, couple with children or couple without children. And one more thing that I want to highlight is the link between poverty and loneliness, I think even now, worse in the cost of living crisis. So you can see like people right now have to spend money on so many different things, and they have to prioritize groceries or housing. So they're going to spend less money to, for example, going out with friends, have a social interaction, or even participate into community activities. So I recommend more research about this issue with more up-to-date data up to 2021.
Thank you.
Thank you.
If it's helpful, just on that, there was a report that came out just last week that I shared with the committee earlier in the week that was done by the Australian Unity Wellbeing Index, where they looked at wellbeing during a cost of living crisis. And they found strong association there between people who were struggling with the cost of living, having to go without, and their feeling of social connectedness and social isolation. So that information is really good to look at. It also, that found the lowest personal wellbeing scores came for those who were unemployed, relied on disability support, or had household incomes below $33,800 a year.
Thank you very much.
Thank you. That was helpful.
Dr. Conn, another question for now?
That was really helpful. My other questions are on totally different topics, so I'm happy if others have got burning questions.
Yeah, you can keep going.
Yeah, sure. So I was also interested, you made a number of recommendations around disaster preparedness and recovery and looking at social infrastructure. Could you speak to how that came out in your research?
Yes, happy to do that quickly. Part of that is it's been an overlap with some of the other work that we're doing. So we've been, with my WACOS hat on, we've been involved in a lot of the Western Australian disaster preparedness work. We're doing a project at the moment that's particularly around heat vulnerability for, particular groups in the community, including seniors, people living with a disability, pregnant women and young children during heat waves, and what their response is. But so certainly that was, one of the kind of concerns there was, and particularly in the discussions that we'd had around people's responses during the recovery phase of COVID, was the interaction between being in a crisis and being lonely tended to, be more likely to impact on people's well-being. And so that sense of social connectedness during a time of crisis is something that comes through really strongly. And I suppose the flip side, that's like, as Lily was saying, the link with single parents is another example of that, where people who are facing adversity, simply the feeling of having some kind of solidarity and support can make a great difference to them. Otherwise, the feeling can often be that they're finding a lot of things to be overwhelming, and so that tends to reinforce their sense of social isolation.
Yeah, so just to follow up, when you recommend sort of building and recovering social capital, I know things like roads are always front of mind for people after a disaster, but what sorts of things should we be considering in that space?
Yeah, look, there's a few key things there, because one of the things that's been interesting is, there've been some work in the past where we've looked at what happens in the disaster recovery period. And often a lot of those kind of small local community service sector organisations and voluntary organisations play a really critical role in recovery. But the flip side of that is that we've found, over half of them, if they're directly impacted and they lose buildings and they lose resources, they disappear and don't come back again. And so part of the thinking is we actually really need to be looking at our community resilience and preparedness and making sure that we're looking at those things, so we're not just thinking about the physical impacts, but so we're ready there to support people, particularly through that crisis and beyond, and use it to help build a sense of solidarity rather than to help people find themselves feeling overwhelmed. And certainly we've had some quite concerning stories recently from some cyclones, for instance, we had in our Midwest, where a lot of people lost their houses and it's taken them a very long time to recover. And some of those communities, people have become very isolated, and some of them, a lot of people have simply left because it's kind of become, too hard and too traumatic for them.
Thank you.
Thank you. Mr. Barrett?
Can I pick up on that?
Yes.
Nearly took my question word for word, so it means I can dive a little bit deeper into this. It's interesting to say the isolation after a disaster, because one thing you do see after a disaster often, and I know we've seen this in Molong and Kidal and Yagara, etc., this way, is the community really comes together. I wonder if you can touch on, possibly through stages of grief, what that means further down the track after they've come together after this incident. I suspect we've then seen a waning of that togetherness that leads to the loneliness that we might be talking about.
Yes, and look, that's a really good point, and I suppose it also depends on the type of disaster and how kind of concentrated or widespread. Certainly the ones where everyone's in it together, and then you get to a kind of shared process of crisis response and recovery. But often then, I think in some of these stories where we're looking where we had, kind of cyclone and storm impacts that were spread over a quite area where the communities themselves were quite small and relatively isolated, it only took a few people who were having trouble with insurance, having to leave the community or something, for people to suddenly kind of lose that, kind of drop below a threshold where the communities were functioning well. So certainly I think deliberately thinking about what are we doing during that recovery period to make sure that we're helping and supporting community participation, that there's things there to help and support people to volunteer, but also then that there's outreach to people who might find that more challenging, particularly if they're seniors or they've got limited mobility as well. So yeah, I think they're just some of the things, but yeah, I think it's a really important question.
So is sort of what you're saying, maybe in a disaster event, and I'm thinking specifically of floods, part of the problem is that support infrastructure then breaks down because, one, they're doing other things, two, as you mentioned before, they've lost their building, etc. So the Meals on Wheels, for instance, might stop because they don't have wheels anymore.
Yes. So exactly, and so certainly, and in one sense, like an event like a flood tends to be more kind of, concentrated in levelling in the way that it has the impacts across the community. But absolutely, there's that problem that you'll often find if you've got shared community infrastructure from a voluntary organisation that gets flooded and destroyed. Often the process by, it probably took fundraising over many years or many decades to get to that point. And they may not necessarily kind of have the insurance, or they may not have the resources or the backup. And so I think it's really critical there that there's some thinking about how does government step in during the recovery period to make sure that there's that active support that's not just about the physical infrastructure, but it's thinking about that social infrastructure at the same time.
I wonder then, we're talking about disasters, that instant disasters that happen in, say, a drought scenario, that is, rather than a quick incident, it's a longer erosion of those support networks. I would imagine that's more likely to lead down that loneliness road as people just slowly slip down the pole.
Yeah, and we've certainly seen some of that, particularly in the northern wheat belt in WA, where basically what we've had is land becoming increasingly marginal, and so what a lot of farms are having to be scale up, and so you're reducing the number of farmers per community because they're working over much larger areas, and you reach a certain point where you no longer have the numbers for the local footy club, or your shops and cafes in town start closing and so on, and that's where it really starts to get cumulative.
Are you happy for me to keep going?
Yeah. I've got some more, but we've got a bit of time. Carry on.
Okay. I wonder if you can touch more on that local footy club, extrapolating that more than just the footy club, but the sort of those organisations and clubs throughout the community. What, as we start to lose them in, say, a drought scenario, what are the ripple effects from that?
Yeah, well, I think that's a really good question. It's kind of been one of the things, I suppose, that we've been very concerned about in some of our regions, and it's, disasters has been one thing. And another of the challenges that we've had in some of our northwest communities has almost been the opposite, because we've had, an economic mining boom, and we've suddenly got a huge, fly in, fly out, or drive in, drive out workforce. And we get to the point where your local community leaders can no longer afford to retire in town, and they're moving down to the big city when they retire. And suddenly there's nobody to run those clubs. And that's where you then kind of see a real hollowing out of the community. And often those things seem a bit, intangible, and you wouldn't think they were that important. But actually, having a social life in the community is what helps people to, stop from being isolated and have a sense of coming together to do things. And often, when there's a disaster or something, you'll reach out through those networks that are your, local footy club or whatever, as your kind of first point of contact for finding other people and, offering or receiving help.
A couple more specific questions. The $1,500 per person you're talking about, cost of loneliness, who is wearing that cost?
Well, so The short answer is that's more or less the increased cost to the community of the, kind of direct impacts on health and well-being. So basically, if people are lonely and more isolated and they're not looking after their health as well, that's kind of one of the direct impacts. But I'm interested to hear from Lily if she's got more she wants to say on that. She may have a better idea than me.
Thank you, Chris. I just want to add more some points about the methodology that we use to estimate the cost. So basically, we estimate the cost based on the impacts of loneliness on different risky health behaviors like smoking, alcohol consumption, and less physical activities. So we basically compare between two different subgroups. People feel loneliness and feel lonely, and people don't feel lonely. And we compare the number of GP visits or between two of them. And we can see that people who feel lonely are more likely to visit GPs or present at the hospital. So that's why we can estimate the cost based on the cost for GP. And we do the same thing for alcohol consumption, for less physical activities, and for drinking.
Could I just jump in, Scott, because that was part of the question I was going to ask. So I'll just jump in. So your costs are strictly health costs?
Yep,
okay.
Related to health.
So just health. So you didn't do anything with regard any modelling, or Dr. Kong, maybe you could, being a health economist, you didn't do anything about productivity loss?
No.
Or just health?
No.
Okay.
We also take into account the number of sick days that the people feel lonely and people don't feel lonely take annually. So that's a outcome from the sick days as well. So it's a bit related to productivity, but not totally.
But only implied. You didn't test any of that. Dr. Kong, did you look at that at all? Did you look at costings with any measure against them?
No, not so far. But like I did read their paper, and I remember they talk about sick days, which I think is quite standard in consider productivity as well.
Okay, but I mean, can I just ask then, is there any other work or research or estimates out there which perhaps use a broader sort of idea of cost? So health costs are helpful because that's very tangible. Governments understand health costs, but productivity costs, we also had someone earlier today say, well, there's also the costs of people not engaging in education, etc. So I guess less tangible. But do you know of any studies anywhere that have that broader sort of cost lens?
Not on top of my head, but can I take this question on notice?
Oh, yes, please. That would be great. And Curtin people as well?
Yeah, we'll have a look as well.
That would be great. Thanks very much. Scott, sorry, Chris.
I was just going to say one of the things attached to that discussion around loneliness and health that we also looked at was the work in the UK around social prescribing. And so this is deliberately tackling the health impacts of loneliness by actually having doctors and registered nurses and so on actually deliberately prescribing to people that they are treating, and this is particularly around seniors or people who are socially isolated within the community, to directly go and engage in voluntary community organisations or activities in their local community. There's a similar program in New Zealand as well that they do a kind of green prescribing stuff where they suggest people go out and get involved in local community bush care groups and stuff like that. So this idea that you can actually look within your health system and you can recommend to people what are some physical activities that you can do that are going to help your level of activity, but are also going to get you directly connected with your community to build your sense of connectedness and well-being, so you start feeling better and you start looking after yourself more and you live longer and better.
Could I maybe replicate my last question and say, if you've got any studies about efficacy or cost benefit of social prescribing, that would also be really useful. We've been talking about it today, and that would be very helpful for us, for both Dr. Kong and for both Dr. Liu and Mr. Toomey. That would be helpful if you can find any.
Okay.
That'd be great. Yeah. Sorry, Mr. Barrett, further questions?
Well, I guess, yeah, just getting close, maybe again on notice. I just noticed the maps that you have in your submission, Bank Curtin. I just wonder, this is obviously a national study, is there a chance we could get a more focused New South Wales map for that? Particularly showing that, like, I know you have Sydney in there, but if we can see a little bit more detail around the regional areas there and see if you have any detail with that, any trends for regional areas versus metro areas or things that we need to be aware of on that front.
That would be
yes,
great.
I think we can send you a better copy of the map. We'll check up on that and send through what we can. And then see if we need to kind of follow up to do some more work to get a better one. But we can certainly dig out what we've got and kind of blow and scale it up so you can see things clearly.
I just want to highlight that the map were produced using data just from 2001 until 2018. So if we want more data update, for example, in 2020, we may need another, a separate study, to update data and then, produce more updated map for Sydney, for New South Wales.
If we could just start with what you've got, that would be really helpful, because I had the same thing. I couldn't actually see, and even with my glasses on, I couldn't really decipher what the map was. But also it did lead me to ask a question that I had, which is, I know Dr. Kong, you spoke a bit about New South Wales experience, but you use the same data, which is the HILDA data, and there wasn't all that much in the Bank West Curtin submission about New South Wales. So likewise, if you do have anything else that's pertinent in what you've already got as opposed to a new study, that may come at a later stage, but now we'll go with what's there. That would be really helpful as well.
Sounds good.
And noting, of course, Mr. Barrett's request about anything regional as well would be greatly appreciated. I have no further questions. Mr. Barrett, do you? No? All good? Dr. Con?
I'm right.
Good. Thank you all so very much for your work, your submissions and your evidence today. You all have kindly agreed, after we harangued you a little bit, to provide us with some information on notice. The Secretariat will be in touch about that, as well as their supplementary questions. But again, we appreciate you coming along and giving evidence today. Thank you.
Thank you so much for the opportunity. I really enjoyed it. My first time.
There you go. Excellent.
Thank you.
Thank you, everyone.
Careful what you wish for, Dr. Kong. We might call you back here all the time.
Yes.
joining us today for our last part of the hearing this afternoon. If I could start by getting you to state your name, position, title, and swearing either an oath or an affirmation. And I might start with Professor Worthrich, who is in the room.
Great, thank you. Sorry, did you say I had to state my name? So
Yes,
Professor...
name, position, and the oath or affirmation.
Thank you. Professor Viviana Worthrich, a Professor of Clinical Psychology at Macquarie University and Director of the Lifespan Health and Wellbeing Research Centre. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. And if we can go to our Monash University representatives online, I think we have, if we start with Dr. Roseanne Frick-Polly.
Hi, I'm Dr. Roseanne Frick-Polly. I'm a senior researcher and life course epidemiologist at Monash University. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Mr. Tashal? You're unfortunately on mute.
Thank you so much. I'm Achamela Tashal. I'm a epidemiologist and a year 3 PhD student at Monash University. And I sincerely and truly declare that and affirm this evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. And Dr. Hatun?
Hi, I'm Dr. Tellington, a year 3 PhD candidate from Monash University. I solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you all very much for that. If you'd like to begin with an opening statement, I'll start with Professor Worthrich.
Great, thank you. Building strong social connections in which people feel valued and supported are important for our social, emotional, cognitive and physical health across the lifespan. Investing in strategies to build these strong social connections at a community level is likely to prevent and reduce social isolation and loneliness across all age groups. But simply encouraging people to engage more in social activities is not enough. Social activities need to be high quality. They need to facilitate connections between the participants that make them feel valued, supported and connected. Practical and psychological barriers to building social connections are common in all age groups and populations, and these barriers therefore need to be identified and addressed at the local level to ensure high quality social activities are available to all people. Whilst building a community framework to build and support social connection is important, there is clear evidence that simply providing opportunities for social participation is not enough to treat loneliness. Instead, to overcome loneliness, people need both access to a variety of social activities as well as access to evidence-based interventions that target those psychological factors that cause and maintain loneliness. This includes the need for practical strategies to overcome unhelpful thoughts about the availability or unavailability of support, by reducing avoidance of social activities that might be about reducing anxiety, building self-confidence and problem solving and individuals' barriers to participation. In order to make a meaningful impact on community level social isolation and loneliness, we also need to invest in more research to develop more potent, scalable interventions. Our submission was based on a large body of research being conducted in our centre, where we focus on understanding these underlying factors that cause social isolation and loneliness, and to develop new interventions for these conditions. This includes several National Health and Medical Research Council clinical trials that we are currently running, which we're looking to evaluate the clinical and cost effectiveness of these interventions for treating social isolation and loneliness in a number of different groups. So based on our submission, we have some very practical recommendations for you. One is to establish a framework for integration of approaches across all areas of government and community. 2, to invest in public health messaging campaign to inform people about the importance of frequent social participation with both a variety of people and groups. 3, to design cohesive neighbourhoods that facilitate both incidental and deliberate social interactions. 4, increase social access to social activities and social groups that provide regular contact with the same people so that connections can be developed over time. 5, identify and target barriers and facilitators to establishing those high quality social connections and participation, particularly in the vulnerable groups. 6, making evidence-based interventions to treat social isolation and loneliness inclusive and accessible to all. And finally, 7, investing in research to improve our knowledge of the causes of social isolation and loneliness and how to best treat these conditions.
Thank you very much. The Monash team, would one of you like to make an opening statement?
Thank you. So our research focuses on how social isolation, social support and loneliness impact chronic diseases from an epidemiological perspective. We consider loneliness and social isolation as social determinants of health. And social determinants of health is defined as the non-medical factors that influence health outcomes. They are the conditions in which people live, grow, are born and age, and the wider set of forces and systems shaping the conditions of daily life. Our research has utilised longitudinal databases from Australia and internationally. In summary, our research demonstrates that social isolation and loneliness are separate yet interconnected concepts. Loneliness and social isolation are not only about the individual, but also the wider community and social environment that supports the individual. Social isolation can increase the risk of loneliness, and vice versa, loneliness can increase the risk of social isolation. Loneliness disproportionately affects older adults. Loneliness and social isolation can be viewed as elements of human nature in the sense that we are all likely to experience them at some point during our lifetime. However, long-term persistent loneliness or social isolation are both concerns as they negatively impact mental and physical health through separate mechanisms. There is an abundance of evidence that people with positive social health are at lower risk of developing serious chronic diseases and death. For example, we have demonstrated that older, healthy Australians with poor social health are 42% more likely to develop cardiovascular disease and twice as likely to die from cardiovascular disease over approximately 4.5 years of follow-up. We have identified that older, healthy Australians can engage in activities to reduce their risk of chronic diseases that are social specific. And we can detail these in question time if you're interested. We have some recommendations. First, we recommend addressing other social determinants of health simultaneously to facilitate socialising and prevent or mitigate loneliness. Second, we recommend that healthy Australians aged 70 years or more seek help for feelings of loneliness if occurring 3 or more days per week over time, to participate in community activities at least once per month, engage in informal caregiving at least once per week. For example, this could be babysitting, childminding, or looking after someone with illness or disability. Have contact with 4 or more relatives or close friends per month. This could be in person, but also includes email, phone, video conferencing, and text messaging. And to aim for 3 or 4 relatives or close friends with whom to discuss private matters with or call for help. And note that only 2 people are required for benefits in health if they fulfil both discussing private matters and calling on for help. Recommendation 3. As there is a gender-based difference in how loneliness influences the risk of chronic diseases, we recommend that gender should be considered in intervention developments. And 4, we recommend social prescribing as a solution to prevent and mitigate loneliness, social isolation, and unfavourable social determinants simultaneously. Thank you.
Thank you very much. If I could just put a question which has been, vexing is probably a bit strong, but on my mind reading these submissions and today, through the evidence, is the difference in cohorts that we're being told are the most at risk. So I think we've had quite a few anyway. We've had young people, we've had women at certain stages of their life, we've had men in certain circumstances. I think, Monash, your submission says older people. So am I to take away that everyone, like we're all in it, which I get that there's a part of that as well, but in terms of groups more at risk. How do we make sense of this? I might go to you first, Professor Wuthridge.
Look, I mean, I think you're being told different things because that's what the literature tells us, right? So different studies do find different things. And I guess it depends for each group what's going on for that particular group at a time, right? So we know that poor physical health, for instance, does get in the way of people participating in social activities and is associated with loneliness. So it makes sense that often older adults, come up in these particular surveys. At other times, and certainly since the pandemic, we've seen this change with younger people now reporting more loneliness. So, right, so studies prior to the pandemic, we didn't see such a strong effect with young people. That has now become more prevalent since the pandemic. So I think there's a difference in, who studies what, when they've studied it, what cohort, what time. But I think the point is that loneliness and social isolation does impact on all populations, right? So it can be those with low SES or for those with low transport options, those in rural communities. So I think it's hard to say that one group is more vulnerable than another. I think any sort of disadvantage really puts someone more at risk of social isolation and loneliness.
Thank you. And the Monash team, whoever it's appropriate, if you want to address that.
I'll be talking to this one. So we agree that it's really about how the sample is collected and how loneliness is also measured. So in our submission, we have a figure that demonstrates the prevalence of loneliness by age among an Australian representative sample of people living in their own homes. It's from the Hilda study, so the Household Income Labour Dynamics in Australia survey. And this was for the data collected from 2001 to 2017 for everyone aged 18 years or more. It showed that people over the age of 75 years were most affected, and we're currently undertaking an updated analysis, which we're happy to share with you when it's available. Just to point out that these are people in their own homes, and I have noted that some samples have collected data from people active in the community, for example, going to shopping centres, and in those samples they report higher prevalence of loneliness from young adults. So it's just important to think about who's already interacting in society, and the difference between social isolation and loneliness here is coming out as well. And another example would be some work that I'm involved in that's funded by the Department of Aged Care, evaluating their Aged Care Victorian Visitor Scheme. And my preliminary findings demonstrate that people receiving aged care, whether it be in-home or residential, are more likely to be lonelier and socially isolated. And this is critical because it's a vulnerable group of older people that is expected to increase in coming years, given the ageing population and social demographics changes concerning lone households as well as smaller families and kinless people. And then to the point of how it was measured in that Hilda survey, it's feeling lonely often, yes or no, as the responses. So it's a direct single question with a binary outcome, which sort of forces people into those categories. And if you have a look at the scales, there are different scales with either one or multiple questions that they then do a calculation with some factors that are more related to social loneliness or emotional loneliness. So it can get quite complicated.
Yeah, it's an interesting one, and part of it's just being an unreformed researcher. We've had several researchers and research groups come in, having analysed the Hilda results, and give us different prevalence, which I presume is the subset you're using within Hilda, but it's absolutely fascinating to see how it's the same data set can be approached in different ways. No criticism, it's just an interesting kind of thing for us to unpack as to what we use. So thank you for that. Back to
before you move on,
yes.
I think Hetlin would also like to add some information about the gender question you had around prevalence.
You want to add something?
Is that okay?
Yeah, of course, yeah.
Yeah, so we were using this healthy older Australian cohort from the nationwide Australia, which is from a clinical trial. It is called ASPRI. And then we used a subset of the Australian population from that cohort. What we have found was the loneliness is higher, the prevalence of loneliness is higher in women, older women, compared to men. But it the thing is, our population is 70 years old at the baseline. So it means that when we calculate their birth cohort, it's going to be around 1940s. So that means the cultural difference may be influencing the loneliness as well. So that means men may not report loneliness, although they may feel it. So there might be some concealment to it.
Yep.
So, but currently we are seeing the higher prevalence of loneliness among older women compared to men.
Thank you. That is a useful thing to point out. I appreciate that. If I could go back to Professor Woolrich, you talk about in your submission your research into treating social isolation and loneliness as novel. Can you tell us about why that's the case and what's different?
Yeah, so I think I sort of also point out in the submission that actually when you pull apart what's being done in loneliness, there's actually not that many studies that have actually targeted loneliness per se. So often there's been a lot of studies that have tried to improve social connections and social participation, and I think it was really thought that if you just got people together, that's how you would fix loneliness, right? And it's really only now we're starting to, as been described, we understand they're different constructs, but it also means that they require different sorts of treatments. So when we start to think about, well, what is it? We know that, you need to have some contact with other people, but what stops people from having contact with other people? And that's when we started to look back at the theoretical models we have around loneliness, but also our own perceptions as clinicians, as psychologists, and trying to understand, well, what is it that lonely people do and say and think? And so we actually spent some time talking with lonely, there were older adults, participating in a trial, and we realised that there was a lot of what we call cognitive misattributions, right? So basically it means ways of thinking about their circumstances, ways of thinking about their social network that were really getting in the way of them then being able to go on to participate in things. And so in fact, with these theoretical models, we do see that these cognitive component is actually a really important part of what maintains loneliness. So people start to believe that they don't have people available to help them and to support them who might actually come and be of aid to them if they need it. Now, in some situations that's true, but it's often a perception, and sometimes that's not an accurate perception, right? We also identify that there are barriers that stop people to participating. Social anxiety, for instance, avoiding of social interactions, just not even knowing how to go about joining a social group, right? For an older person who's lost a spouse, their family's moved away, it's all very well to say go and join a social group, but for these people, they might not have made a new friend for 40 years, right? And this actually becomes an incredibly daunting experience, lack of confidence. So we then applied cognitive behavioural therapy skills to say, how do we address those barriers, those psychological barriers, right? And so we have, I really do think, the only ones to have really drilled down in that space. We're spending a lot of time understanding what those underlying cognitions are. We've developed a scale which we're validating in a couple of samples now to sort of detect what are those unhelpful thoughts that people think to themselves. We've now done some experimental work to identify how we can change those thoughts and the resulting impact to improve loneliness. And we also have some behavioural strategies which we are using as well. And so in fact we've just finished a clinical trial where we're looking at this. So very shortly we will have the results to show whether or not we have been successful in actually making a big difference to loneliness in older adults.
That's really interesting, because one of the questions that I had was, in your submission you talk about interventions that targeted social isolation that have an effect on social isolation, like decreasing social isolation, but don't automatically lead to reduction in loneliness. And a lot of the submissions we received, a lot of the evidence we received, while they differentiate at the beginning the theoretical difference between social isolation and loneliness, it seems conflate the solutions.
It does.
So what I'm hearing is, yes, those interventions work on social isolation, but you're suggesting that actually the loneliness aspect is a more individualised thing that will need other interventions targeting individuals.
Correct. And so, in fact, that's what the literature tells us too. So when you look at interventions that have been successful in targeting loneliness, so far they have been psychological interventions that use some sort of way of targeting changes in behaviour and changing cognitions in some way, right? Others haven't really drilled down on what the fundamental cognitive basis is in the way that we have done. But we know that, those sorts of strategies, those cognitive behavioural therapy strategies have been applied in a couple of different formats, in some of them digital, some of them face-to-face, some of them group. They're the ones that we're seeing actually have an effect on loneliness.
And before I pass to my colleague, those results which you said are soon, how soon is soon? Are we able to?
Within the next 4 weeks, we'll have the final 12-month assessments done for that clinical trial. So, I can try and put a little bit of action on the analysis for that.
That would be great. Even just preliminary analysis would be really helpful. We'd appreciate that.
Yeah.
Over to Dr. Corn.
I have another question about sort of measurement and data, because we've heard today very clearly that social isolation and loneliness are two separate but related things, and that social isolation is a risk factor for loneliness, but that they're separate and need to be measured separately. So I'm interested, when you look at interventions, and we've had a really broad variety of things recommended to us today, what's the best practice for measuring the success of an intervention? Are you aware of anyone measuring the impact on loneliness as opposed to only measuring the impact of interventions on social connection?
Yes. So, I think a clinical trial is the best way for us to establish the true effectiveness of an intervention. And so clinical trials randomise participants to an intervention versus some sort of control condition, right? And we do that because that's how we tease apart what the active ingredient is. What is the thing that's making a difference, right? In terms of studies that are measuring changes on loneliness, so yes, our study is one of those, but there is, of course, a current a number of projects happening right now as part of a targeted NHMRC call, which was to target loneliness in people with chronic conditions and to examine the interaction between those things. And as part of that, at least 2 of the groups are actually evaluating an intervention for loneliness in that population of people with chronic conditions.
Thanks.
Okay, so we're hanging
open to a comment from Monash too, if they want to answer the same question or not.
Well, I did hear that you're, first of all, interested in the difference between social isolation and loneliness, and I was not able to include it in our submission because it's under embargo, but I've written the chapter on social isolation and loneliness for the Cambridge Handbook on Loneliness, which I can share on notice confidentially if you are interested in the definitions and theoretical frameworks underpinning these two and how I see them impacting health differently through different mechanisms. And then your question was more around how do we look at that in terms of interventions. Well, I guess the way I've seen it is that something like social prescribing, which is what I mentioned earlier, it has the benefit of improving both as well as increasing health equity. And social prescribing is defined as a means for trusted individuals in the clinical and community settings, like a general practitioner, to refer a person to a link worker who can connect them to non-clinical supports and services within the community to address their non-medical needs to improve the health and well-being. And there are different models. We advocate for the link worker model because this gives enough time at the individual level, which is, I think, what we're both saying here is that we need to have individual level interventions where personalised plans can be developed between the link worker and participant that are tailored to the person's specific needs and interests. And another key component of social prescribing is that it can also have benefits in offering services to overcome social determinants, so social structures that are preventing someone from interacting with others that may not be addressed by other interventions. Thank you.
Can I have one more? Yeah. I was also interested, Monash, in your written submission and in your opening statement, you made some very specific recommendations for healthy older people, and I say very specific in terms of the numbers of relatives or contacts that you're recommending. Could you explain how you arrived at those really specific numbers for contacts?
Yeah, my question
Yeah,
exactly.
of course. So I'm going to let Hetlin and Chirley discuss some of their, finer details. But I will just point out that most of this research is undertaken in the Australian sub-cohort of the ASPRE study, which is the aspirin in reducing events in the elderly trial, where it was a randomised controlled trial of aspirin, low-dose aspirin, and it had no effect on the outcomes. So all of our outcomes were adjudicated, meaning that we had very strong measurement in cognitive decline, cardiovascular disease in a healthy sample at age 70. So I'll let them both go into details.
Yeah, so we were studying, we were using that cohort study to follow up these healthy older Australian for around 10 years. So I'm looking at the dementia as an outcome. And we were studying beyond loneliness, actually. Loneliness was one of the exposure that we measured. And then we have additional 24. So in total, we have 25 social connection activities because loneliness is actually one of the umbrella terms. Social connection is one of the umbrella terms. Then loneliness is one of the terms included under the social connection. So for example, you may see that babysitting and child minding, because we consider that as a social connection activities. And then we have found that men who did babysitting activities actually reduced the dementia risk by about 25%, which is significant for us. So that's how we arrive some of the specific activities and numbers over there. Yeah.
Okay. Thanks, Chair.
Thank you very much for that. Professor Woodrich, I'm just picking up on some of the themes that we've had throughout the day and getting some responses. You spoke about, in your opening, high quality connections. And we've been talking and asking questions about social media, online engagement today. And I just wanted to get your thoughts on the role of social media and how that intersects with this idea of high quality social interactions.
Yeah. So I just want to preface that by making two points in that, and in fact maybe I was meant to say I was tabling some recommendations. I don't know if you saw that, but anyway, they're just some really practical things that spoke to some of those other recommendations. But I guess the first point is there's a whole piece that can be done within the community just about building social connections in general, right? That's going to just help get the population in a good place, build connections that are probably going to protect them, right? So we've been talking a lot about how we treat loneliness. So when we think about digital platforms, I think digital platforms have a great role to keep continuing these social connections, right? So it's good for people who have connections. It keeps them, connected to other people. When we look at interventions that have actually tried to reduce social isolation, yes, that works because they have more frequency of social contact. We know that interventions that have used digital platforms to treat loneliness have been successful when they have used those psychological strategies I was talking about before. So they are therapy groups to target social loneliness by targeting those thoughts and getting them to change their behaviour. So we know it works when it's delivered digitally. So again, I think it depends on what the use of the digital platform is for. If it's again just about saying, let's pop you into a community group and get some people together, that may or may not work to treat loneliness unless people feel connected to the group, valued and supported by the people in the group, where they feel like there's a shared sense of identity with those group members. And so you'll see I've made some recommendations in here where we've thought about how we might be able to think about how we can, train community leaders or have options for training for people who run groups within communities to give them some strategies and tips about how do you help your members in your group, whether it's the Men's Shed or the Country Women's Association or the soccer group. How do you help people build those connections in a way that they then go on to feel and build these high quality connections?
Thank you. I guess that goes on to my next question. And again, you mentioned this, I think, in your introduction or one of the answers, about scalable interventions. One of the things that we're hearing a lot about is the importance of place, so local things, which makes complete sense, but also I worry about in terms of, we're a state government, what's the role in that? So when you're talking about scalable interventions, and you've just mentioned, I guess, some things, can you talk a bit more about what you mean?
Yeah, so one of them is about saying how do we upskill what's happening in the community. There's great stuff that happens in the community, but we might be able to make that better, right? By making it more accessible to people. Lots of people don't know about what's in their community, so we can scale within the local environment by just actually making it known what's around and helping to develop those quality interactions within those local groups. But I also thought, scalable can relate to digital, right? We can, once we have developed digital interventions to treat social isolation and loneliness, we can make them accessible through one of the many, available platforms we have, MindSpot or other sorts of groups, right? At the moment, I don't think we have any that at least have been evidence-based, that have been evaluated, but I don't think that would be a hard ask to do something and to, generate some data around that.
Thank you. And I do note that we have a colleague online, the Honourable Scott Barrett, who wants to ask a couple of questions. Go ahead, Scott.
Thank you very much. I have been listening in. Sorry that I've been a little bit disengaged. I've been travelling. But I think Dr. Freppoli, sorry if I've got that wrong as well, but you mentioned some really practical, almost KPIs before that actually quite excited me. I just wonder how you landed on those in particular.
Scott, I think Dr. Conn might have asked that, but we'll have a quick recap. So you're talking about the 2 people, the 4 people, that kind of thing?
Yeah, well, sorry, if that's been answered, that's fine. My next question, my follow-up question was then going to be, how troubling is it to you to see the decline in the organisations you're referring to, such as the clubs and organisations, the volunteering groups? They're drastically reclined over the last 20, 30 years. How concerning is that in the loneliness context?
So this is more of a personal opinion, in the sense that I feel that we need more equitable resources. So at the moment, there are options for people, but often they cost money. And if we could find a way of subsidising so people could afford socialising, and even people can't afford the transport to get to places. So we're talking about huge inequity to socialising in that respect. So that's where I would think part of the way I feel like the social prescribing model could go would be to alleviate people of the cost of joining some of these social groups. And also the link worker can work towards finding ones that are less expensive or free, which are available, but sometimes can be hard to find.
And what about their role as almost the prevention of loneliness? Like before someone's going down that track and needs to be, I guess, referred to one of these organisations, if these organisations are there and strong and people involved, do we think that could then somehow stop more people becoming lonely or having that social disconnection?
I think that what my research has found is that you don't need a lot of people to feel socially supported and reduce loneliness. So I feel that, first of all, I noticed that earlier in one of your sessions you were talking about social isolation, and it's seen as an objective measure, but actually we do have some subjectivity around that with, comparing ourselves to other people. So and thinking that we need more friends, and if we understood that maybe we only need 1 or 2, 2 or 3 for our health, that's a really important message to get across first. And then if we, sorry, could you just repeat the question again?
Yeah, the role that it can play before, as a prevention.
Yes. So, sorry, I lost my track of thought there. So, first of all, we only need a few number of friends, but the thing is that over our lifetime, our friendship groups will change over time, and this is natural. So we need to have avenues of refreshing our friends. And if we do social prescribing or are interacting in our community, we find those more easily, is how I think about it. So that in my mind makes sense to reduce loneliness, but I haven't seen any data around that. So it just makes sense. But I would like to ask my colleagues if they would like to add anything specifically.
No.
If not, I might pass back to Professor Wuthridge, who may have some thoughts on that as well.
No, sorry. I've forgotten actually the question. I was busy thinking about something else I was going to say. So
It was the preventative potential of the types of organisations which we might socially prescribe to
yes.
after the fact.
Yes. No, I think so. There's lots of evidence showing this association. The more frequently people engage in things, the less likely they are to experience social isolation and loneliness. We know that the best predictor of well-being in later life is actually, the size of your social network when you're younger, right? So having lots of friends in your 40s actually sets you up for life. And so I think really these sorts of clubs and activities actually set everybody up throughout their lifespan to have the support they need, but to also have friendships that they're going to lean on down the track. Right? So for older people, they often end up lonely because they rely on friendships from 40, 50 years ago, right? People they literally did those community activities with. So I actually think a huge piece here is re-engaging everybody in these sorts of community activities. Now, obviously, we need to have more community activities which are low cost, right? I think that can be a burden for a lot of families is when it's expensive or they have to transport their children or their teens or themselves finding time to get there. So, in our submission, one of the recommendations we made here was a lot around thinking about the built environment, right? And there is actually a lot of research that shows that having the right sort of built environment actually fosters more social contact and actually reduces loneliness, where there's where people can just go and hang out. And they don't have to be just cafes, because cafes are expensive for people who don't have money, but it's the parks, the gardens, it's the equipment, it's the free chess sets, it's any sort of activity, but they do need to be those regular activities, because remembering we're not just trying to have like market days or one-off days. We need people to be reconnecting with the same people where they are building those strong relationships. So when they're in need, they get to turn around and ask for social support.
Thank you. I have a related one, and then Mr. Barrett, if you've got more. We haven't heard a lot about loneliness and the workplace and what role work potentially has in prevention or mitigation. Or I don't know if either group has thoughts. Professor Wuthridge, I'll let you go first, and then we'll go to Monash.
Yeah, look, I don't know a huge amount other than that it is a problem, right? And there is some research showing that, again, reducing loneliness in workplaces occurs if you have structured social activities, so regular, whatever it is, Friday afternoon teas, regular lunches, often if they involve some sort of free food that attracts people out of their offices or attracts them in for the day. So I think it's not that different to what we see in at the outside community, but we actually have to put some structure in place for some people.
Thank you. And Monash, do you have any comments on the workplace sort of side of things?
Yeah. I know that it has contributed to the cost of loneliness, the fact that loneliness when in the working adult population contributes to absenteeism and productivity, but also that when someone leaves the workplace and are going through that change in their lifetime, it is a time of increased loneliness. So there is certainly a relationship there.
Okay, thank you. Mr. Barrett, did you have further questions?
Just one random question that I hope I'll just ask it. Is there such a thing as generational loneliness? In that, if one family, if a single parent is lonely, that then gets passed on to the kid who doesn't pick up those skills?
That's a great question. I don't think we know, but if I had to take a guess, if someone is lonely, they tend to interact less with others, right? That's what, loneliness is associated with social isolation. So if a parent is becoming more socially isolated, we would predict a pretty good chance that the kids are having less social interactions, right? Because mum or dad or whoever's not going out.
Okay.
But it's a good question.
It's a great
research
question.
project.
I was going to say someone's PhD is just sitting there waiting. Any comments, Monash, on that one?
We have looked at spousal loneliness and that impact on relationship together in the same household using the Hilda study, as well as on their death outcome. But we can't share that at the moment because it's under embargo, but I can share it privately on notice if you'd like.
That would be great. Thank you very much. Further questions from Mr. Barrett or Dr. Conn? No?
I'm very good, thank you.
All good. Excellent. Well, with that, we are at the end of the session and the end of the day. I just want to thank you. Oh, yes. Sorry,
Well, I just
Professor
wanted to make one
Woodbridge.
comment because
Yes.
I was listening before and you were talking about social prescribing.
It's come up a lot.
It has come up a lot, and I think actually the Monash team will actually have something to say a little bit about this too, because I know that one of them actually published a systematic review and meta-analysis on social prescribing
Oh, I
for
love that too.
chronic conditions, I believe. So listen, in preparation for this, I actually went and spent a little bit of time searching the literature, right? Because I knew this was going to come up.
Yes.
And you know it's a very popular concept and it's been rolled out regularly through the UK. When you look at the literature, there have been a number of what's called systematic reviews and meta-analyses. So they compile all of the research in the area and say, basically, in summary, does something work? And the meta-analyses will then be comparing the size of the effect against some sort of active control. Now, this is a little tricky and lots of people won't want me to say this, but the results are not often that great, right? So, but I think the problem is that social prescribing is quite broad, right? The name of it suggests that we prescribe social activities, but not necessarily, right? So people can be prescribed to receive lifestyle interventions to deal with a chronic condition, right? So it's actually hard to then go away and work out, well, what happens if you're picking someone who's lonely and you're trying to connect them in with social activities? So I think there is some hope. There is some reviews that suggest at least social prescribing that combines nature. There is some evidence for that. There is a trial that was done in the University of Queensland. It was Australian Research Council funded intervention in the Mount Gravatt area. There is a preliminary report available. It wasn't an RCT. They didn't randomise people, so it is just a pre-post evaluation. They report significant benefits in loneliness, so I think around 11% reduction in loneliness. And you'd probably need to talk to that team for the University of Queensland. But I know they spend a lot of time using that link worker, but actually trying to overcome some of those barriers I was talking about before. So I think it's the evidence is mixed. I think if it was to be used, I think it needs to be used carefully, right, in terms of for certain sorts of conditions with certain sorts of prescriptions. And again, if we could make sure people are trained who are delivering it to identify what those barriers are and to overcome some of those psychological hurdles, I think there's great promise, right, because it sort of does what we think it does, which is connects people in their communities to social activities. So I think as long as we can bolster their skills, it's probably helpful. But I'll let the Monash team comment because I know they've done some stuff in this space.
Before I do that, I'd say thank you very much. I think in a previous session we asked the witnesses for any evidence on efficacy because it's
I can send you the systematic reviews. There's about 6 of them that I was reviewing in preparation for this.
That would be really, really helpful. Thank you so much. But I will let Monash respond if they so wish.
They'll probably disagree with me. That's okay.
That's okay. Monash team.
So I don't know where to start. I think I want to start at a point where I agree with you, and that's that social prescribing is a very broad term at the moment. And this is where there's different models that are considered social prescribing. What I would really hope for people to stop using the word social prescribing is when a healthcare professional says, hey, I've got this great group activity that I would like you to do, and they give them one option. Now, that's currently could be considered social prescribing, but that's not the optimal version. The optimal version is someone sits down and gives them one-on-one support to think about what their needs are, what their interests are, and also to determine if they've got any social determinants that are preventing them from socialising. In some of the, I'm currently evaluating 2 pre-post analyses, so they're not randomised controlled trials. One is in mental health space, and one is in with people with chronic diseases. And what we found is sometimes just that first link worker appointment to remind them of their prior interests is enough. They don't need necessarily a social prescription. It's sort of like permission that you're allowed to go and engage in these things. And have you looked up this website and showing them, just sparking it is enough for some people. And they seem to have just as good outcomes whether or not they've seen the link worker in these evaluations that I'm doing preliminarily. I would say that from my research, I've seen benefits in the models of social prescribing using the linked worker with the one-on-one, if that helps with how we're seeing it. There is, sorry.
No, that's fine. Sorry, finish off.
I was going to say there is another model that it's called the Frome model, which is not necessarily called, they won't call it social prescribing, but it's another way of increasing this sort of social fabric. And this is where there's certain people that have taken a little bit of a course or understanding, like hairdressers, podiatrists, just generally people in the community that like to talk to people. They do like a little a session to find out more about how they can promote activities, and they just do it to everyone they talk to, and they try to get people going to places that they're going to and sort of invite them. So there are different models. That model might not take into account sort of social services that some people may need, but it's another way of building sort of social fabric, I guess. And again, that's not necessarily called social prescribing, but another way of increasing awareness.
Yeah. All right, thank you very much, and thank you very much for that last intervention. That was really, really helpful given the evidence that we've received and are still going through. With that, though, we are calling the session to its end and saying thank you. And again, we will follow up with the Secretariat on the things that you've very kindly agreed to provide on notice for us, and there may be supplementary questions. But thank you once again for your research, your submissions, and your appearance here today. Thank you very much.